அவுட் வரல, ரெக்கார்டிங் போட்டீங்க, சவுண்ட் கேட்கல. இந்த மைக்
Good afternoon, esteemed faculty, respected judges, staff. Myself, Dr. Samreen, junior resident in the Department of General Surgery. Myself, Emily Immaculate Mary, research scientist in the Department of Medical Oncology. We hope you all had an insightful and intellectually stimulating sessions at the poster presentation. To continue with the spirit of academic curiosity and engagement, we now move forward to the next session of our program, which is oral presentations. We'll now begin our first oral presentation session for non-student research staff. I'd like to invite our moderator, Dr. Srira and Shahana Ashma from Department of Medical Oncology to take over the proceedings. I would also like to introduce the judges for the first session. Dr. Shyama Sudha Prem from the Department of Radiation Oncology, Dr. Hemachandran M from the Department of CTVS, Dr. Swaroop Kumar Sahu from the Department of PSM. Welcome, sir.
Faculty members, distinguished judges, colleagues, research scholars, and dear participants, a very warm welcome to this non-student research staff oral presentation as a part of our 11th JIPMER Research Day 2026. It's my privilege to chair this important academic segment along with Dr. Shira and Dr. Varsha for the period of 2 to 3 p.m. here at the JIP auditorium. At the onset, I would like to acknowledge the leadership of the institution for providing a vital platform where scientific inquiry, innovation, and collaborative research are celebrated in such enthusiasm and rigor.
Before we begin, there are instructions. Each presentation is 10 minutes in total, 7 minutes for presentation and 3 minutes for discussion. And we will be strictly adhering to the time schedule in the interest of fairness and discipline. So we will provide a gentle reminder by 5 minutes with a bell, and a request to closure at 7 minutes with a bell. And only the presentation order may respond to the questions. So it's clear that the presentation is 7 minutes total, and 7 minutes and 3 minutes for the discussion. So let's begin. Our first presentation explores an often overlooked but deeply meaningful milestone in pediatric oncology survivorship: school reintegration after cancer treatment. May I invite Ms. Soumya Devi S, Clinical Research Coordinator, Department of Medical Oncology, to present her work titled "Exploring School Reentry Issues in Children Treated for Cancer."
Good afternoon, everyone.
I am Soumya Devi, Clinical Research Coordinator from the Department of Medical Oncology. The title of the study I am going to present today is Exploring School Reentry Issues in Children Treated for Cancer. Advances in pediatric oncology have significantly improved the survival rate, but survival is just the first step. The quality of life after survival is also essentially important. The term school reentry refers to process of returning to school after cancer diagnosis or treatment completion. Because school is the place where the child can regain their normal routine, reconnect with their friends, and continue their academic learning, which supports their social and emotional recovery. However, in India, data on this area is limited. The primary objective of our study is to determine the prevalence of school discontinuation among children treated for cancer and to evaluate the extent of delay in school reentry. Secondarily, we want to understand the factors associated with the delayed reentry for children with cancer and to evaluate the impact of cancer treatment on academic performance. Coming to methodology, this is a cross-sectional observational study conducted in Regional Cancer Center, JIPMER, from the period of September to December 2025. We choose a convenient sample size of 150 children. The inclusion criteria was the children should be in a school-going age, which is above 4 years, and they should complete their intensive phase of treatment or on their oral maintenance therapy. Exclusion criteria is the children deemed unfit to rejoin the school by the treating oncologist. For statistical analysis, we used descriptive statistics and chi-square test. The data was recorded using a structured questionnaire which was developed based on the literature review and clinical experience. The domains included in the questionnaire was demographic, clinical details, school reentry pattern, academic challenges, and social behavior. This questionnaire is externally validated by a multidisciplinary panel, which include pediatric oncologists, psychiatrists, teacher, a survivor, and a biostatistician and a public health representative. The suggestions from this are incorporated in the final questionnaire. This is an interviewer-administered questionnaire. The responses are recorded prospectively in the Google Forms. This is the study flow chart. So totally we screened 156 participants. Out of which, 6 of them were excluded from the study because they didn't meet the inclusion criteria. The remaining 150 were enrolled in the study. This is the result. So coming to demographic characteristics, the median age group of our study population was 11 years with the range of 4 to 22 years. Male was predominantly higher than the female population. Most of the children families were lived in rural areas and majority fell into middle and lower middle income categories. Coming to clinical details, larger proportion of our study had hematolymphoid malignancies, primarily leukemia, followed by lymphoma and solid tumors. The duration of the study, duration of the treatment was categorized based on their malignancies. Most of the children had completed their treatment and still some of them were on their maintenance therapy. So out of 150 children assessed, 128, that is 85% had rejoined the school, while 22 of them were not rejoined the school at the time of assessment. Among those who have rejoined the school, majority reported a positive school reentry experiences. However, not all the reintegration was good because 27% of the children reported academic difficulties. This is mainly because of inability to catch up the studies during the treatment period. Regarding absenteeism, 70% of the children took 1 to 3 days leaves per month, which is mainly because of hospital follow-up visits and the leave due to fear of health issues. Coming to social outcomes, 5% of the children experienced peer discrimination and no one reported the discrimination from the teacher. The median time interval between the diagnosis to school rejoining was 13 months with a wide range of 1 to 84 months. Similarly, the median time interval between the treatment completion to school rejoining was 5 months with a range of 0 to 6 months. While focusing on non-attending children, the major reasons for non-attending were fear of treatment-related side effects, and a small proportion of the children had reported school-related restriction, which underlines the institutional barriers. And 45% of the children were attending private tuition instead of normal schooling. Importantly, most of the children had expressed the willingness to return to school, while 4 of them had not interested to return to school. And the factors as analysis, we analyzed the several factors. We analyze the several factors. Factors among these, male sex and the duration of cancer therapy was found significant with the school reentry. Similarly, duration of cancer therapy was again found statistically significant with the academic challenges. Coming to discussion, almost most children had rejoined the school, while 15% of them remained out despite being medically fit. Longer duration therapy was strongly associated with the delayed reentry and academic challenges, which is similar to the findings reported from the Western studies. Similarly, a delay of more than a year to rejoin the school is described in the Western study. Academic difficulties persisted due to inability to catch up after a prolonged absence. Fear of side effects and parental concerns were the key barrier in non-attending children, which is also similar to the results from Western studies. Coming to limitation, this is a single center study and conducted in a public sector hospital, which limits the generalizability of the results. On conclusion, this study highlights the critical gap between the clinical recovery and functional reintegration. These findings highlight the need for the structured school reentry support as a part of pediatric cancer therapy. These are the references. And thank you.
Thank you, Ms. Soumya. This study probably highlights the reintegration gap between survivorship and care and reminds us that recovery is not complete until normalcy resumes. And the floor is now open for questions.
From 16 of them were on completed treatment, 9 of them on maintenance.
So why is it difference that patients who are on maintenance, it's only 9 while you're taking to that 15? Were you able to identify any factor? Because maintenance means they would be receiving some form of treatment. But you would expect that side effects will be there, and there's a proportion of patients who will be the school drop would be the dropout rate would be.
Possibly, ma'am, but we didn't include that factor.
Second question regarding the age group of the 15% of patient. Like, which was the most common age group? Have you divided it, characterized it, presented? High school, yeah.
Equally, 11 of them were in the 4 to 12 ages and 11 of them in the remaining.
Here is a very broad age group. We're looking at the high school, yeah.
Yes, we split it accordingly based on the education. We split it from middle ages, from primary to middle school, we included in 4 to 12, and after that, we included in engineering.
Where was it?
Equally split it. 11 in 11.
You identified barriers for school dropouts. So what was the positive factors which make the students, like 85% of the students join the school? Joining, is there any positive factors that you've identified?
Positive factors.
For the reentry, you've identified barriers to student dropout. On the contrary, what are the factors that actually generate the students remain students?
Mostly academic interest and own interest. Majority of the children reported that returning to school because of their own interest.
And why is you think the father's education, mother's education? Was there any competition?
No, like that.
So the children after they completed therapy, they'll be joining 1 year better than the class to be 1 year better than the.
Yes, so most of the children reported that they joined in the lower grade.
Was there any specific difficulty in online because they have joined 1 year lower grade than they were?
That is very, they cannot connect with their older friends. That peer discrimination. That.
So was it a significant factor for those only 2 children?
No.
If you only specifically those only children whether they have joined 1 year lower class than they did before. Okay. What is the best of validity of take for your
Right for this.
validating the question.
Questionnaire. So we've developed the questionnaire based on the literature, and this is the
Any internal validity, external validity?
external validity.
Only internal validity.
Thank you. So if wanted, you may continue. One more minute.
I just one question. Why did you do convenience sampling and how many were actually eligible during the study period and what proportion of the cases you have included in your study?
We chose convenience sampling because of the time and resource constraints. We wanted to set up a preliminary data on this. That's why we chose the convenience sampling. Next question.
What proportion of the eligible participants were included in your study? What proportion of the eligible participants were included in your study? 136 only you have included. How many were eligible?
154.
Okay.
Out of 156, 150 of them were included.
Thank you. Now we move on to the next presentation. Our next presentation examines the effectiveness of genetic testing criteria in identifying hereditary breast cancer, an area with major implication for precision oncology. I invite Ms. Nandini, Project Technical Support, 3, Department of Surgery, to present a study on multi-gene panel analysis and universal testing strategies.
Good afternoon, everyone. I'm Nandini, Project Technical Support from ICMR Genetic Testing Project. Today, I will be presenting our study titled Evaluation of Testing Criteria for Hereditary Breast Cancer using Multigene Panel Analysis in Newly Diagnosed Breast Cancer Patient at JIPMER. Breast cancer is the most common cancer in worldwide, and in India, it accounts for 9.7% of cases. Around 10 to 15% of cases are associated with hereditary cancers. Current guidelines such as NCCN and ASCO mainly recommend genetic testing based on age, family history, and personal risk factors. However, multigene panel-based universal genetic testing can detect pathogenic variants that could be missed if we only focus on established criteria. The main objective of this study was to compare NCCN and ASCO criteria with the universal criteria to determine their effectiveness in identifying pathogenic variants among the newly diagnosed breast cancer patients. This study was conducted at JIPMER under ICMR Genetic Testing Project. A total of 485 patients were included from July 2024 to January 2026. All these patients were categorized into respective testing criteria based on their eligibility. And these patients underwent multigene panel-based genetic test using NGS and with the MLPA. All these patients received both pre and post-test counseling. And the clinical data, demographic data and all recorded and entered in the retina-based database. So coming to the result portion, demographic data shows the mean age for the patients who met NCCN and ASCO criteria was 50 years, and for those who tested through universal criteria is 69 years. And regarding family history, majority of the patient doesn't have significant family history. In terms of hormone receptor, TNBC is very low when compared with other receptor status. So out of 485 tested patients, 48 patients, that is 9.9% of patients tested with detected with pathogenic variants. The figure 2 represents comparison between the genetic result of the tested patient based on their criteria. 10.10% of patients have pathogenic variant who met in criteria, and for those who has tested through out of criteria have 7.69% of pathogenic variants. And a total of 485 patients have pathogenic variant. Among them, 44, that is 91.7% of patients met in criteria, and the rest 4, that is 8.3% of patients have pathogenic variant who have tested through universal criteria. We also analyzed parental consanguinity, hormone receptor, and family history among the pathogenic variants, pathogenic patients. Here you can see the parental consanguinity is also, majority of the patient doesn't have parental consanguinity, and half of the patient doesn't have a significant family history. And also the TNBC is also comparatively less when compared to the other hormone receptor status. So these findings suggest that we can detect pathogenic variants even there is no strong family history or classical high-risk factors. And this figure shows the distribution of pathogenic variants in patients between the criteria and out of criteria. So here in out of criteria, that is 2 out of 4. 50% of patients had changes in the clinical management, as these two patients have genes in pathogenic variant in high and moderate penetrant genes. So Pramanic et al. Reported high prevalence of 18.6% of pathogenic variant compared to our study, which shows 9.9%. This may reflect region-specific genetic variation or and population heterogeneity. So this suggests that you know this suggested we need to know the importance of region-specific data for to determine the accurate uh, accurate study genetic variants. And then next one is our study shows 8.3% of pathogenic variant, those who are tested through out of criteria, and 50% of them have changes in the clinical management. Similarly, Shelton reported 11.4% of pathogenic variant through out of criteria. In conclusion, our study shows additional finding through universal testing, and also we have changes in the clinical management that would be missed if we only rely on the established criteria. Thank you.
Thank you, Nandini. This work underscores the value of universal genetic testing in uncovering clinical actionable variants that traditional criteria may miss. Now the floor is open for questions.
I mean, I think presentation management has changed. We have identified the different behavior.
Yes, ma'am. So because so here there are four in criteria we have done clinical management based on the high and moderate penetrance gene. For low penetrance gene, some of them doesn't have clinical management, but in out of criteria we find out one variant, that is BRCA2, that is a high penetrance, and another one is APN, that is a moderate penetrance gene. These both genes need a clinical management map. So that's why out of 4 patients we have done 2 patients have clinical management, changes in the clinical management.
How would the test be validated? How would be to identify variations of unknown significance also, and to identify epigenetic variants also. So how is this test validated?
Yes, ma'am. So this test was outsourced only. So we gave this test to the MedGenome lab. There they use the ACMG guidelines in order to segregate the variants and then genes. So based on that, we have done that test now and this study. Thank you.
What do you propose for the clinical management of the cancer? Do you propose to test genetic testing for all the patients who fail this, or do you want to modify that based upon your
We need to test all. My study is based on we need to test all the newly diagnosed breast cancer irrespective of the age and any other criteria. Because if we rely on the any established criteria, in the sense we would be miss this rest of the pathogenic variant patient. So it would be better to do the universal testing, even though the
given that the testing criteria is not good.
It is useful, sir, but we should not rely only the established criteria. We should not rely the established criteria.
So what all other clinical factors you want to put in those criteria so that the when you test based on the criteria, the outcome get at the end of that is 15 minutes. But like out of 480 patients, how many got tested positive?
Out of 480 patients, 44 tested.
Only 44
Yes.
tested. For other 400 patients,
Yes.
how much is the cost of the genetic?
Normally it would be 5,500 rupees, but because of this project, it is free of cost.
No, out of these those three criteria, which one is the recommend? You are informed the criteria and other systems. Which one will you recommend for clinical? In out of following which criteria the outcome of.
Universal credit.
So you propose to do genetic testing for all the patients.
It's better on this.
Anyone from the audience have any questions? Thank you, Ms. Nandini and Joseph.
Thank you.
So we will proceed to our third presenter. So the third presentation addresses symptom science and the quality of life measurement through linguistic and psychometric validation. I invite Dr. Madhuvarshini to present a study on the Tamil translation and validation of the chemotherapy-induced taste alteration scale.
Good afternoon, everyone. I'm Dr. Madhuvarshini, working as a project technical support from the Department of Medical Oncology. Today, I'm going to present a study named Tamil Translation and Psychometric Validation of the Chemotherapy-Induced Taste Alteration Scale, that is CITAS. So, chemotherapy-induced taste alteration is a common adverse effect of patients who is receiving chemotherapy, but it's a very under-recognized in routine oncological practice. It leads to decreased appetite, nutritional compromise, and impaired quality of life. So, despite its clinical relevance, it is very difficult to elicit the quantification of this taste alterations. There is no clear intervention for its management. The CITOS is an 18-item validated instrument for assessing taste disturbances used internationally. However, a culturally adapted and psychometrically validated Tamil version has not been available. Hence, we planned this study to evaluate the reliability and construct validity of the Tamil translated chemotherapy-induced taste alteration scale among cancer patients receiving chemotherapy. So, regarding methodology, the study is designed as a cross-sectional psychometric validation study, and which was conducted among patients who is receiving chemotherapy and who is above 18 years of age, and the exclusion criteria will be of the patients who is under some metabolical disturbances, or the patient who is not able to take oral intakes, or excluded from the study. And the procedure involves, after obtaining permission from the original authors, we are using a structured forward and backward translation methods, followed by expert panel review to ensure the conceptual, semantic, and cultural equivalence. After that, we are pilot tested were conducted over the 10 patients to assess the feasibility of the scale. So after the pilot testing, cultural adaptations were implemented without altering the core content of the original CITAS value. And then data collection were included 90 cancer patients who is receiving chemotherapy were interviewed using the Tamil translated chemotherapy-induced taste alteration scale, that is CITAS. After that, out of which 30 participants were again retested, again re-interviewed using the same questionnaire within a 4-hour interval for retest accessibility. And following this, psychometric validation were analyzed using the construct validity, which is exploratory factor analysis, and reliability test and item level analysis were conducted for the statistical purpose. Then the structure of the CITAS instrument. The CITAS instrument is classified based on the 4 major domains, which is decline in basic taste, general taste alteration, phantagogia or paragosia, and discomfort. And decline in basic taste, which refers reduced ability to perceive the normal taste. That is difficulty for the patient to elicit the normal taste, including soreness, bitterness, salt, and sweetness. Umami is a combination of 5 tastes, which includes which tastes like some brothy of a meat or something. It's a sour flavored taste. And the general taste alteration include overall change in taste alteration with difficulty in tasting food, difficulty in tasting
difficulty in perceiving the smell of the food are included in the general taste alteration. And in phantagogia and paragosia, they were classified as the patient having abnormal or distorted taste perception. And in discomfort, there is some unpleasant taste changes during eating. It includes feel nauseated or reduced appetite. Some questionnaires were introduced in the discomfort part. And in the psychometric validation, so to determine the construct validity, sampling adequacy was confirmed using the Kaiser-Meyer-Olkin test, and the Borlas test was statistically found to be significant. This proves the construct was the sampling adequacy was confirmed, and the exploratory factor analysis revealed a stable 4-factor structure, which explaining 61.9% of the total variance, which is found to be consistent with the original CITA scale as designed. And regarding reliability, the Tamil CITAS demonstrated excellent reliability with a Cronbach's alpha of 0.92, indicating a strong internal consistency and corrected item total correlation within acceptable range. For test-retest reliability, we used the Pearson correlation test and the intra-class coefficient, which is about 0.932 for Pearson, which is statistically found to be significant. And in the intra-class coefficient, the value is of 0.917, which confirming the excellent temporal stability. So out of 90 patients we included for the psychometric validation study, 52 of them were female, and 28 of them were more than 60 years of age, with a mean age of 52.77, with a standard deviation of 11.09. And the majority of the patients included were gastrointestinal cancer patients, which included the stomach cancer, gallbladder, pancreas, and colorectal, followed by the breast cancer patient, and most of the patients were receiving curative chemotherapy, which containing the regimens of platinum-containing agents included carboplatin, cisplatin, and oxaliplatin. And out of 90 patients included in our study, we conducted the clinical and descriptive statistics. In that, the mean score of the total CITA score is about 38.56 with a standard deviation of 15.3. This indicates a moderate degree of chemotherapy-induced taste alteration is found in our study population, with a considerable variability across the patients. And so, based on this mean, we categorize the patients into mild, moderate, and severe. So the patients having a mild symptom of about 20% of the patients having mild taste alteration symptom, and 63.3% of the patients having moderate taste alteration symptom, and whereas 16.7% had a severe taste alteration symptoms. This indicates the importance of recognizing taste alteration symptoms in patients undergoing chemotherapy. So, in item level analysis, there was no significant floor and ceiling effects were observed over the study, which confirms the appropriate discriminative capacity. So, we also explored the association between the severity of taste alteration and with the demographic and clinical characteristics of the participant. We found there was no sound statistically significant association between those two variables. And in the key findings of our study include the Tamil translated CITAS version shows external internal consistency, indicating a strong item homogeneity and strong test-retest reliability with a four-factor structure, which is consistent with the original developed CITAS scale, and there were no significant floor and ceiling effects were observed. So, to the conclusion, the Tamil translated CITAS demonstrated a strong internal consistency, excellent reproducibility, and satisfactory construct validity. So, this based on this study, we are implementing this Tamil translated CITAS in upcoming study involving zinc supplementation for improving chemotherapy-induced taste alteration patients. Thank you.
Thank you, Dr. Puducherry. And the floor is open for questions.
Next slide. Is it possible that those 90 people whom you have included, do they represent the whole population who are coming to JIPMER? Indirectly, I'm asking sampling is appropriate or not?
We are just using the convenience sampling, and the sample size we chose based on the factor to determine the exploratory factor analysis. For running the EFA, we have to need at least 5 to 10 patients per item. So CITAS is an 18-item scale. So we included 5 patients for one item. So based on that, we calculated 90 patients. I accept this is very difficult to generalize for all the patients.
So we'll done external validity too, sir. Later on, we'll done. Yes,
Yeah,
sir.
I
It's very
understand.
yes, sir.
Depending on the working time, whenever you are free of doing. But you should give some notion of whether these people are representative or not. So
Okay,
that,
sir.
so that, when you
It will be
are done,
applicable to us.
this result are valid.
Okay, sir.
Can be
Okay.
extrapolated
Okay,
or not, that you can mind for now.
Okay. I'll try to generalize.
Why have you clubbed both curative and palliative? Perception of case might be different with patient on palliative treatment. Why don't you focus on maybe curative alone and a separate set of patients there? Separate questionnaire for rather than clubbing. 40% of your patients are having. 60%. Okay, on patient-based perception maybe.
Me different, but we didn't elicit in such a way.
How do you take into account the difference between the taxing scan? You have patients who receive taxes of the pancreatic cancer. That itself can reduce the alteration in the case. How have you taken into account? You have taken the question. Why don't you know homogeneous or uniform coverage? Yes,
No separate reasons for that. We just try to validate the scale in a communal setting population. That's why we designed it such a way. We are not thinking in that way. Anyhow, we up.
To study the conclusion you got it as not who have test application knowledge. Have you planned any?
Yes, zinc supplementation for improving the taste alteration after the patient's receiving chemotherapy. That's our upcoming study.
Thank you. We move on to the next presenter. Our fourth presentation explores patient perception in tele-supervision care, a crucial area in post-treatment oncology services. I invite Dr. Shweta Raj to present a qualitative study on understanding patients' unwillingness towards tele follow-up.
Good afternoon to all. Today, I'm presenting the study title, Understanding the Patient Unwillingness Towards Cancer Survivorship, Tele-Follow-Up, a Qualitative Study. It's a part of a pilot project which helps to evaluate the feasibility and acceptability of a newly designed survivorship plan. To briefly provide the context of the study, conventional outpatient follow-up phases major challenges such as overcrowded clinic, logistical challenges, and time constraint and travel difficulty for the patients. To address this, our team has developed a nurse-led teleconsultation-based survivorship care plan, and a model pilot study is currently underway to evaluate the feasibility and acceptability of survivorship care plan and for the adult solid cancer survivors. During the implementation, we found nearly 1/3 of the participants or the eligible patients were unwilling to participate for the tele follow-up. Understanding the reasons of the reluctance become the focus for the qualitative study. Before moving to the qualitative components, we'll see the background of the pilot study. We have conducted a one-group pre-test, post-test, quasi-experimental study to assess the feasibility and patient satisfaction of a nurse-led teleconsultation survivorship care plan among adult cancer survivors who completed curative treatment and echo performance status 0.2 and fluent in Tamil. These are the inclusion criteria. And between May and October 2025, 305 cancer survivors were screened, and out of that, 103 were enrolled. And however, 107 eligible participants were declined the participation. To understand the reason for the reluctance, we conducted the present qualitative study. Moving on to the qualitative part, the objective of the study to explore the factors influencing the unwillingness towards tele-follow-up among adult cancer survivors. We conducted a cross-sectional qualitative study at the Regional Cancer Center, JIPMER. Using a purposive sampling, we recruited the participants who declined the pilot tele-follow-up program. 6 in-depth interviews were conducted until the data saturation was reached. With each interview lasted up to 20 to 30 minutes, and interview guided explored the participants' perception of the remote follow-up and their attitude towards the remote follow-up, reason for the unwillingness or the hesitation, experience with the health system and communication, and the suggestion. Later, the data is analyzed using Atlas TA software. And moving to the result, This is the participant profile table, and we interviewed 6 participants aged between 37 to 62 years, and there are 4 females and 2 were male. Most of them are from urban background, and majority were breast cancer survivors. Overall, these provide a reasonable diverse range of socio-demographic and clinical perspectives. And overall, the provided these 4 major themes emerged from the qualitative finding. The one is structural technological barrier, and the next one is clinical and safety concern, and the third one is psychological and relational factors, and the fourth one is social and family influence. We'll see each of them. And the first major theme is identified in the patient's unwillingness towards daily follow-up. The first one is structural and technological barrier. Participants describe the limited access to the digital device and unstable internet connectivity. Low digital literacy may also depend on the family members to operate the mobile devices. One participant has mentioned they are not aware of the video call or the message, and that such facilities were not available to them. In addition to that, system level issues were also present, that is collecting medicine remotely or arranging investigation made telefollow feel incomplete. The second one is clinical and safety concern. Many patients strongly preferred the physical examination. They felt doctors need to check the body directly and perform the test to ensure everything is normal. As one participant described, the main concern was checking the body and taking the test. Third one is the psychological and relational factors. The hospital visit provide the reassurance and emotional comfort. Seeing the doctors in person created a sense of trust, comfort, or the satisfaction. One participant explained that preferred coming to hospital visit because of they are scared or something might happen if they are taking the treatment at the home. Finally, the social and family influence. They have played an important role. Healthcare decisions were often discussed in family members. Some participants said they would able to ask their family members before accepting the teleconsultation, and teleconsultation was generally considered acceptable only when patients the condition was stable, like a conditional acceptance. And we explored the participant suggestion on the feasibility of tele follow-up. However, most of the participants did not provide a specific recommendation for the feasibility of teleconsultation. Our findings aligns with the international evidence showing conditional acceptance of telehealth. Although studies from Qatar and United States were reported general openness, and our participants have greater safety and concern and structural barriers. Similar to Pakistan, most preferred a hybrid model rather than the replacing in-person care. To conclude, reluctance towards the telesurveillance follow-up, it's not simply a resistance to the technology, but it reflects the clinical concern, safety, and the practical challenges. Many survivors perceive teleconsultation as less safe and less thorough about the case than the hospital visit. A hybrid model can be recommended as a recommendation, supported by counseling and structured orientation and digital literacy support may improve the acceptance and implementation. This study has certain limitations, including a small sample size, that n is equal to 6, and reliance on a telephone interview without the non-verbal cues, and possible social desirability bias while answering to project nurse staff, and inclusion of only unwillingness participants without comparing with the willing participants. And additionally, the short study duration limits the generalizability. These are the study progress, future direction. The pilot study is ongoing, and the interim report has been presented as a poster, and RCT has initiated and implementation outcome are being assessed. These are the reference, and thank you.
Thank you, Dr. Shweta. This insightful qualitative explorative reminds us that technology adaptation must be patient-centered, not context-centric. The floor is open for questions.
Especially duration of survivorship, duration each patient, like how many years post.
Currently, we are 3 months. 3 teleconsultation has been done for our.
See how all patients were uniform, like 1 year, 2 years, 3 years after completion.
It's more than 1 year.
More than 1 year. So do you think it make a difference if the patient is losing 5 years after completion? If there be no need for telecommunication, it can be. So what is the fixed ratio? What is the distribution?
More than 1 year has been taken.
Teleconsultation, what is the modality?
Teleconsultation as conducting within the 3 months interval for a 1 year. We are including the questionnaires such as psychosocial issues we are adding and monitoring the recurrence, side effects, late effects, and how many times they got any issues in between the 3 months. It's a video call, audio call that can be done based on their preference. We are looking.
So your patients, were they using smartphone or what was the
Some
they
patients
faced,
are-
regarding technological standpoint?
Most of the patients are not using the smartphone. They are doing only normal calls.
But
And-
those 6 patients whom you have included for telephony calling, 4 were from urban, 4 were from rural.
Right.
Those even from urban where they're not using any smartphone.
That we conducted as a telephonic normal calls. We didn't use the normal video call.
Nice study. But maybe we do try to elicit what will motivate them to take part in this. I mean,
For the unwilling,
and for the yeah.
willing patient.
What modification will them to participate more?
Currently, for the pilot study, we are taking a feedback for the willing patient. Means already enrolled patients we are taking. So they said it helps to reduce the travel time and if there is no long waiting time for them and able to talk more. We are actually conducting it for 20 to 30 minutes kind of consultation. That is not happening in the normal OPDs.
No. What I was asking is, if you ask about their what they will suggest, so that what will make them participate more. So they are not ready.
Okay.
So what is their suggestion?
We have given the details, sir. We can, you should not come to JIPMER. We can talk in online and.
I'm suggesting the details. Sir, ma'am, are you suggesting the details?
No, not a replacement. We can reduce the burden to the physicians, ma'am.
We now move to assembly. Lens to health systems. And then the data driven decision making. It's a national program and GD program. And I invite Mr. Nandu Krishna J, Senior Consultant, Department of DMSM, to present Worldwide Care Cascade Implementation Framework.
Good afternoon, everyone. I'm Dr. Nandu Krishna J. I'm here to present my work on development and final validation of a two-tier care cascade interpretation framework for NP-NCD program decision making. So coming to the NP-NCD digital ecosystem, I'll just explain. The village level ASHAs has a ASHA app for feedback assessment. Then sub-center level, the ANMs has a app for screening and follow-up. Similarly, facility level, there is an MO who has a portal for diagnosis and entering the diagnosis and treatment. And the district level and state level also has portal for monitoring and evaluation. There are other partners also involved for from the technical side. So what is about my project? So basically the NP-NCD portal generates a lot of data, and currently the data, there is a fragmented data utilization where there is a static dashboard and there is a limited digital capacity among health workers. So there was a need for a digital implementation for the NCD care, which further needed a implementation research. So thus our project was born, and this is a multi-site project with 3 target goals, 80% target goals, and we are now concentrating on active utilization of portal data for program decision making. So my project has 3 phases currently. The formative phase is over, and it's currently in the co-design phase. So this is our formative findings, where we understood that there is an evident gap in the cascade of care, and this is not just in the programmatic side, in the clinical side also there is a programmatic cascade of care differences, and digital entry was found to be very poor with no structured interpretation package, and the dashboard that was available is very static And currently they have to download patient line list for interpreting some results, and also there is only fixed inbuilt indicator or weights. The currently month-to-month indicator is not available. Also, a quick review features are also not available. And this is a quick glance into the medical officer portal, which is having a status dashboard. Also, there is a work plan. And where there is, in case of a health official portal, this is a key program indicator dashboard along with the geographic performance indicator, where you can see a fixed indicator there. So thus we understood that there is a structured interpretation layer that was needed. But currently the NP-NCD program doesn't have a development partner. And we asked the NHSRC, which is our technical implementation partner, but due to the current feasibility issues, the portal enhancement was not done. So we developed a prototype of an analytical dashboard which we could demonstrate to our stakeholders, and thus our project was born to develop and pilot validate a two-tier care cascade interpretation framework that standardizes the NP-NCD program review using a portal data. And now coming to the methodology, this was a pilot and validation study done in the 34 healthcare facilities using a Microsoft Excel software with Power Query automation. So there were 3 phases, which I'm going to tell about the results of the first phase, which is the needs assessment and the framework development. The further internal validation and pilot testing is ongoing. So coming to the phase 1 need assessment and the framework development, it was done in 2 tiers. That is till the facility level, and the next phase was the programmatic supervisory level. So we understood that there is a clinical gap that is not accounted for in the facility level, and also action-oriented review is needed. And in the program level, there is no quick review model, and structured cross-facility performance is not at present there. So we understood that care model needs to be developed and adopted from other frameworks like WHO Care Cascade framework. And we did a modified Delphi-based expert consensus to come to our indicators. And finally, we developed the analytical framework for the same. So we are taking the downloadable reports from the current portal reports, putting it into a new Excel, which can automate the cascade restructuring. And then at 2 levels, in the facility level, it does a new dashboard and the downloadable reports through till the village and the facility level, and the supervisory level data can be done into facility performance score, and a geospatial mapping was also done. So coming to the development of the same, there was 2 dashboards that was developed in the facility level: Cascade of Care Analytical Dashboard and the ABA-based Digital Readiness Dashboard. So going to the supervisory level cascade development, we did a facilities-wise stage proportion estimation along with the normalization for inter-facility comparability. Composite facility performance score was then calculated using a cascade-based weighting, and then a geospatial contextualization was done. So coming to my results, so these are the dashboard that was developed, which has, the first figure A represents how we can upload the current downloadable Excels and then log the population in the system. Then we will get an analytical dashboard where it can do a month-to-month comparison so that the MO can understand where he needs to act on. Whereas the supervisory dashboard has a facility performance score, which was developed by us, and it shows the critical facilities that needs him to be addressed, and the top 5 and bottom 5 facilities will be can be seen along with the spatial visualization board that was developed with the dynamic monthly FPS board also that was developed. So coming to the strengths of my study, this uses the routine NP-NCD portal data and records. No modification is needed. It standardizes the cascade interpretation. Also, multi-level applicability is there, and also spatial contextualization has been added. Whereas in limitations, this is basically dependent on the data completeness, and also it reflects the recorded care only. But the effect on the decision quality is not yet formally evaluated. So I will tell that the conclusion of my study is this interpretation layer has been made, which converts the routine NP-NCD portal data into a standardized program summary, works with the existing digital infrastructure and generates a very actionable programmatic insights. And the way forward is you can use this into the routine supervisory meetings and automate the current paper format form to reporting along with the time series impact on the decision quality. This can be also taken up for other frameworks in the other programs also, as it is a 2-tier program. And these are my references. Thank you.
Thank you, Dr. Nandini, and the floor is open for discussion.
Of the limitations and accuracy. So the entire thing depends upon the completeness and accuracy. How are you taking care of them?
Ma'am, currently, the paper-based system and the digital system is simultaneously running. But as Pondicherry health system is concerned, we are in the process of converting the whole paper system into a digital system in the next 2 to 4 months. So our SPO has told us that the paper system totally will be taken away from the clinics. So they have to report only through digital. So the current system of lack of digitally documenting will be accounted for in another 4 to 6 months is what we believe. Ma'am, we have running internal validation right now with the last 3 years data, and we'll be further beta testing it in the programmatic review meetings in the upcoming months. So hopefully in another 6 months we will be able to tell a proper,
How do you think by implementing this two-type healthcare system will help in improving the NCD program?
So currently there is the program reviews. I'm talking about the Pondicherry concept. So in the Pondicherry, the MOs has to go through a dashboard which is not interpretable. There is only status that is currently cumulative and not well versed. They can only download reports that is starting from the date of the portal. So they have to manually sort for each month, and data may not be that easily derivable. So in the facility, that is a best thing that we can do. In the programmatic level, in the supervisory level, I would suggest that this helps in a quick glance of whether a taluk is underperforming, whether a clustering of the geospatial clustering is there, and if one specific facility is underperforming for last 2 months, it can be.
We'd like to one slide, I think. Something from
Yeah.
So dynamic monthly that ranking, what are the parameters you are considering for to decide this?
Sir, facility performance score was decided based on the 5 cascade of care indicators that we developed through the expert Delphi method. So that is screening rate, diagnosis rate, then the treatment rate, follow-up rate, and control rate. So this is already established in the WHO care cascade framework. So we have adopted it, and we have done first stage-wise proportion estimation has been done.
The
Weightage was done as a no, sir. It is a cascade of care analysis. Weighting was taken. We already did a sensitivity analysis for the same with different weights. It was coming almost similar to the same cascade of care weighting analysis. So we have taken weights like for each thing we have taken as the control rate is coming, the weights will be more, sir, because the program implementation is done.
Thank you. Now we move on to our last presenter.
Thank you.
Our final presentation addresses integrated emergency care across time-sensitive conditions under the ICMR India EMS initiative. I now invite Dr. Monica Dev, Doctorate Research Scientist, Department of Emergency Medicine and Trauma, to present her work on developing and evaluating a patient-centric emergency care module.
A very good afternoon to everyone present here. I'm Dr. Monica. I'm presenting our National Health Research Priority India EMS initiatives from readiness gaps to measurable gains, iterative facility level emergency care strengthening. So Puducherry was selected as one of the 5 districts among all over India, including Madhya Pradesh, Odisha, Punjab, and Gujarat. So Puducherry being a dense, having a dense health infrastructure as an advantage, still there exists emergency preparedness. So our study aimed to co-develop and iterate facility-level integrated emergency care strengthening model for time-sensitive emergency conditions in Puducherry. These were the 7 time-sensitive emergency conditions identified from NITI Aayog report. So methodology, our study design is concurrent mixed methods implementation, where we iterate, co-design and implement the framework. Study setting was in public health facilities in Puducherry. This implementation was done across 35 public health facilities, including all
32 PHC, 2 CHC, and 1 DH, which is a census sampling. And for the competency assessment, medical officers and nursing officers were recruited, and using opportunity sampling where any state level meeting is organized, we utilize that opportunity to do the competency assessment, and live observations to evaluate the care processes. For the qualitative component of this study, we utilize the in-depth interviews and focus group discussions with healthcare providers, and the study results were triangulated for integration. So referral pathway, a baseline community survey was conducted, and we found that more than 50% of the population were reaching the government hospital and PHC, and hence strengthening these health facilities is essential. So in the formative phase of our study, we did a facility level grading where diagnostic facility, competency of the medical officers, nursing officers, and then treatment facility was all taken into account, and then we did this level grading mapping for all 7 emergencies. And then facility readiness, 43% of the PHCs only had ECG, and 3% only had digital systems. In the spider web diagram, you can see the medical officers training gaps was most minimal in maternal, neonatal, and poisoning. In DH level, all 3 DH of our Puducherry system lacked formal triage area. And so in the next co-design model development phase, we co-designed model 0. A co-design phase is like experts from all departments come together, and national level co-design model is invented with intervention strategies and implementation activities. For this presentation, the key intervention which is made was toxicology training of trainers workshop, which was done by the state. The state nominated the medical officers and nursing officers, and 40 medical officers, 46 nursing officers were trained. And the training effectiveness was from pre and post, there was an increase in their median scores when done with paired t-test. And then the poisoning priorities increased from 53% to 95%. And for the live observation, pre and concurrent evaluation was done, and median disposal time was found to be 9 minutes, which improved drastically from 87 minutes. And then in the co-design model 1, we again intervention strategies and implementation activities were done. And in this, I would like to highlight the triaging and the high-level expert committee formation. In the triaging, state-level co-design workshop was done after the national level workshop, and 8 high-level expert committee subcommittees were formed for all emergencies, and members from all the important institutions from Puducherry are part of this high-level committee, and the recommendation from this high-level committee will go to the MD/NHM and then to the Directorate of Health. So the triage plan was implemented in the government district hospital, and the triage area is established in this implementation program at IGMC. So model 0 achievements, before 43.8% of the PHCs had ECG, and now 3 more additional ECGs have been given to PHCs, and so there has an increase of 53.1%. And then toxicology training improvised the competency of the medical officers, and model 1 enhancements, triage areas were established, and SOPs were formalized for all 7 emergencies. So these SOPs are vetted at the national level by the ICMR experts, and each committee will recommend SOPs to be disseminated to the public health facilities. And you can see the members have approved this, and it will be launched at 10th of this month. And qualitative interviews were also done, and then you can see the absence of clear protocols, and medical officers were having difficulty in recognizing poisoning type, which was contracted by our interventions, and knowledge scores improved, and triangulation of quantitative and qualitative findings shows that time sensitive metrics also improve. So this is our IR logic model where we go back and do a refinement in the model 0, and we do improvements in the model 1. Conclusion: facility assessments identified critical gaps in triage systems, emergency infrastructure, and diagnostics, and we would like to recommend institutionalized triage systems and disseminate SOPs. And public health implication is strengthening the facility level preparedness, thereby delaying the management of emergency care.
Thank you, Dr. Monica. Now the floor is open for questions.
So basically, you are trying to suggest that identify what are the health facilities which can cater to the referral. Or because in Pondicherry there are tertiary hospitals.
Yes.
So do you think that any PhD level categorization will
Sir, in the SOPs, there is a level-wise specific SOP made, sir. For example, level 0 is free hospital and ambulance. Level 1 will be like whatever facilities will have that diagnostic or treatment facility will be coming under level 1. So any PHC, CHC which has all the requirements of level 1 will be categorized into that.
uh, uh, this is a very nice concept actually. But thing is, question is whether it will work here in Pondicherry. Pondicherry because all the tertiary hospitals are adjacent. So,
Yes, sir.
so that is, did you feel any limitation for that?
Sir, since the tertiary care centers are very reachable by the patients because of the dense infrastructure, still there is a overburden of the tertiary care centers, and we would like to level the treatment facilities, and we would like to strengthen the PHC. If the patient goes in this map, you can see that referral map, 50% population go to PHC, sir, and then GH. So when they are going to GH, at least, PHC, at least stabilization should be done, and then referral pathway should be proper. So through this implementation research, we are doing that, sir.
Any questions from the audience? Okay, thank you, ma'am. This session has showcased a remarkable breadth of scholarship, from survivorship reintegration and genetic precision medicine to psychometric validation, telehealth acceptability, and NCD program analytics, and emergency system redesign. I congratulate all the presenters for their scholarly rigor and disciplined adherence to the time. Thank you for the judges and audience for your participation. And now I conclude here and I request that everyone to be seated until our next academic session starts. Thank you. have 7 minutes for their presentation, followed by 3 minutes for discussion and questions from the audience. There will be 2 bell signals to guide the speakers, the first after 4 minutes and the second at the end of 7 minutes presentation time. So without further delay, we will start with the first presentation. Obesity has emerged as one of the major public health challenges globally and is closely associated with several non-communicable diseases, including diabetes, hypertension, and cardiovascular disorders. With the background, I invite our first presenter, Dr. Vembu K. from College of Nursing, will present his research titled Effectiveness of Nurse-Led Intervention on Weight Reduction Among Adults with Obesity in Urban Areas of Puducherry, an exploratory sequential mixed method study. Dr. Vembu, the stage is yours.
Good afternoon, everyone. Here I'm Vembu. My title is Effectiveness of Nurse-Led Intervention on Weight Reduction Among Adults with Obesity in Urban Areas of Puducherry, an exploratory sequential mixed method study. To introduce, a statement from WHO highlights obesity raised globally from 13% in 2006. 16% in 2022. And also the study done by Sivanandam et al. In Puducherry in 2019 revealed high NCD burden in Puducherry. And also many international studies, they highlighted and proved that NLI offers personalized as well as long-term motivation to the people. And my research question was, what's the effectiveness of nurse-led intervention on weight reduction among adults with obesity compared with general care in urban areas of Puducherry over a 12-month period. The objectives were to explore the barriers in reducing weight among adults with obesity and to develop nurse-led intervention to address obesity, to evaluate the effectiveness of NLI on weight reduction, and to identify the factors which facilitated the weight reduction among adults who achieved successful weight reduction, that is 5 or more percentage through NLI. And this study was approved by Ethical Committee JIPMER and permission obtained from Health Research Wing Puducherry and registered with CTRI before proceeding. And this study methodology is exploratory sequential mixed method design conducted in urban Puducherry. And here we went with 5 phases, and in phase 1 we have screened 982 adults from urban primary health center from the selected villages. And in phase 2, we have conducted 4 FGDs with obese adults using semi-structured interview and to explore the barriers. And in phase 3, we have conducted 1 more FGD by using the data of the previous FGD to develop nurse-led intervention and validate it. And in phase 4, we have conducted RCT, and for that we recruited 438 obese adults from the screening list. And we have used WHO STEPS questionnaire to conduct baseline, follow-up, and the midline assessments and inline assessments. And in in-depth interview, we have conducted with the 13 persons who successfully reduced weight, that is 5% using semi-structured IDA. And in screening, almost we have identified 63% of the obese adults equally falls in obese 1 as well as 2 category based on the Asian classification. And through FGD, we have identified some of the barriers, that is unhealthy dietary habits and sedentary lifestyles and lack of sustained motivation as major barriers. And the experts suggested for NLI mainly to include the individualized or tailor-made dietary counseling and physical activity. Mainly they insisted walking as outdoor and Surya Namaskar as indoor exercise, and also with the continuous motivational support. And here we have recruited 438 adults, and we have allocated 219 in each arm, nurse-led intervention arm and general care arm. And during the follow-up, we had 3 last to follow-up in NLI and 3 in general care. And at the end line, we got totally 5 in NLI as well as 6 in general care arm as last to follow. And in baseline assessment, all parameters were comparable in WHO STEPS questionnaire except hypertension. And later on, we have done stratified analysis. It proved that hypertension was not confirmed. And we have Again, as a result, we found through RCT, at the end of the 12 months in NLA arm, we had 12.6% of weight reduction in NLA arm, as well as the minimum of 1.7% of weight reduction in NLA. Maximum it is 12.6%. And other parameters like all anthropometric measurements, including BP, we had a statistically significant reduction. And also we have got a reduction in other lipid profile as well as thyroid profiles and glucose profiles. And IDI revealed that the improved nutritional practices and regular physical activity and support strong support and motivation from nurses as well as from family and also self-regulation that sustained their weight reduction. This is what we have revealed. And obesity prevalence was higher than the national estimates because we got around 63 in Puducherry and with the female predominance and a greater burdening among educated, unemployed and low-income groups we identified, and also findings aligned with previous evidence linking to obesity, lifestyle patterns and NCD comorbidities. And nurse-led intervention can be integrated into routine primary care for the obesity management. And also this study is recommending standardizing NLI with goal setting, tracking and simple digital support, and also suggesting that expanding the NLI to community, especially to the rural settings with the long-term follow-up. And also this study has some of the limited to only Puducherry geographical urban area, and most of the data it is completely with self-reported lifestyle data. And this intervention included only limited exercise modalities like walking and Surya Namaskar, and follow beyond 12 months was not assessed. So these are all the references.
Thank you so much for the insightful presentation. The study highlights how culturally adopted nurse-led interventions can support sustainable weight reduction through behavior change and community support. We will now open the floor for questions from audience. How see the behavioral changes, and how do you think that the this nursing there has helped more than any other person?
Ma'am, in field especially, we have like continuously we have home visit as a part. So nurses, and not only nurses, our healthcare team, we can contribute, and thus it reduces the manpower for medical personnel. That's what we feel.
Okay. But don't you think there are things that are separately developed and evolved in nursing than other people?
Yes, we.
Communication skills.
Yeah, we need some of the qualities to have communication, because most of the people, they were resistant when we contacted at the first time. Even to give consent for screening, they refused. And we 3 or 4 times we have approached. Then only we have started like cooperation, and this is all we got. So we need some
duration. Does it matter the results? Duration of.
Yes, ma'am, definitely. Yeah. For baseline, almost we took 4 months to collect data, and for the intervention implementation for in one because we have conducted in Anganwadi centers, we have collected the people those who are residing in the same locality. So almost 2 weeks it took to only to teach apart from follow-up. So like that, we have covered totally 8 urban primary health centers. So it took long time, and almost follow-up was for 12 months for each.
What were the compounds that you have encountered? So the patient started taking any anti-obesity drugs?
No, ma'am, that and all we have excluded considering the.
During the study, you have followed up for 1 year.
Yes.
So there are many of them were newly diagnosed with diabetes. So they started taking any metformin which reduced their weight. Apart from your intervention, what were the other factors which could have influenced?
Actually, they were unaware of about their glucose level, lipid level and all. Through our lab test only, I have revealed that you have this much of lipid and glucose profile. So later on, we have referred them to their medical practitioners. Like that only. But during the baseline, whatever we have included, it is without any confounding we have included. But hypertension, it was similar with
both of them.
So even one person developed a new diabetes during that 1 year period. That data is what I'm asking. But in general, I wanted to know specific data on how many were started taking any drugs for thyroid or for diabetes. Do you have that?
Yes, ma'am, but in study we didn't include about treatment and all, but just we have collected only how many are diagnosed with hypertension and diabetes, and we proceeded with that.
It's a very good study. Thank you, Dr. Vengu. Now we move on to the next.
We have mentioned about your intervention. We are not able to understand the volunteers, different, whether difference in their level of education, their understanding of the intervention. Just like what was pointed out, whether there were any other diseases among these patients about 9.
Yes, sir. Among our intervention group, we found many, they didn't reveal during baseline data analysis, baseline assessment, but during the follow-up, when we teach Surya Namaskar, they expressed other related back pain, joint pain, and also for them, and it was like tailor-made, so we didn't force to follow. Only walking, it was a mandatory, and Surya Namaskaram, we didn't insist. And they had a lot of health complaints, abdominal pain, and all the report. Thank you.
Now we'll move on to the next presentation. In individuals with chronic kidney disease, metabolic factors can further accelerate disease progression and increase cardiovascular complications. To explore this important area, I invite our next presenter, Mr. Clinical Associate from the Department of Biochemistry, present on utility of central obesity indicators in cardiometabolic risk assessment in chronic kidney disease. Mrs. Lindsay, please proceed.
Good afternoon, everyone. Today, I'll be presenting on the utility of central obesity indices in cardiometabolic risk assessment in chronic kidney disease patients. To start with, the CKD is a public health problem with a high prevalence rate in India. And one of the major mortality reasons in CKD patients are cardiovascular disease. And this, one of the major factors is altered glomerular metabolism that leads to vascular calcification and also phenotypic changes in the vascular smooth muscle cells. Traditionally, BMI is used as an early indicator for cardiovascular risk assessment, but it does not indicate the central adiposity. So recently, Tonicity Index, Body Roundness Index, and Lipid Severity Index, which is actually depicting the central adiposity, has been studied as an early indicator of cardiovascular or cardiometabolic risk in various studies. So, but this was not much explored in CKD population, and that was our interest. And the objective was to compare these three indices between the cases and controls to see if they can be used as a predictive marker for cardiovascular disease in CKD patients. So after the ethical clearance, we recruited 90 cases and 90 age and gender match controls after inclusion and after clearance of the inclusion-exclusion criteria. All the data was recorded in a standard protocol, and the indices was calculated using a validated formula. And for determining the cardiovascular risk, we used FRS, Framingham Risk Scoring, and the analysis was done. SPSS software we used, and based on the distribution, appropriate tests were used for the analysis. Moving on to the result. Comparison of baseline characteristics stated that there was increased BP, smoking status, hypertensive status, and Framingham risk score in the cases when compared to the controls. And comparing the biochemical parameters, we found there was dyslipidemia in cases when compared to controls, mainly decreased HDL levels and increased VLDL and triglyceride levels. To define the cases, urea and creatinine levels were found to be elevated significantly, and there was alteration in calcium and albumin levels in these two groups. And when we compared the central adiposity indices between the cases and controls, we found that the lipid centrality index and body roundness index was significantly elevated in cases when compared to controls, whereas in chronicity index, we didn't find any statistical significant difference. on correlation analysis of these indices with hypertension and triglyceride, we found that there was a strong correlation in BRI, LC index, BMI, and FRS score with hypertension. And all the indices with FRS was correlated with triglyceride levels. And when a correlation was done between the indices and FRS, we found that all the 4 indices were correlated or showing association with FRS. So based on this, we went in for regression analysis, and we found that in regression model, though 4 were showing correlation, only the body roundness index and lipid centrality index showed a strong association with Framingham risk score as a dependent variable. The chronicity index and BMI did not show any statistical significance. So basically, the pathophysiology in the CKD pathophysiology in CVD pathophysiology in CKD is mainly because of mineral metabolism alteration along with dyslipidemia. So our study also did show the same pattern, and this was actually evident with other publications by Day et al., Kaysen et al., Zedi et al., and we also found that in few studies like Thomas published by Thomas et al. And Kane et al., we found that LC index and BRI can be a better predictor of cardiometabolic risk when compared to the BMI. And in our study also, we did find a significant difference between the cases and controls. And so this symbolizes that it can be used for prediction of cardiometabolic risk. And as already known, the Framingham risk score analysis is generally done for cardiometabolic risk assessment. We did find a strong, significant increase in these scores in CKD patients. And all the 3 selected indices were actually correlating with FRS. But when we moved on to the regression analysis, we only found the lipid centrality index and BMI being associated with the FRS. And so this can be used as a independent predictor of cardiovascular disease risk in CKD patients. So to conclude, these 2 can be a better predictor when compared to BMI. Few limitations are that my sample size is actually lower to show the evidence, and I have used only cases without CVD. So if it was compared with the group like CKD with complication with CVD and CKD without CVD, it would have been a better evidence. And the more better evidence it would have been when if it is a prospective study with a follow-up with the endpoint as cardiovascular disease. Thank you.
Thank you for showing the potential role of central obesity diseases to support early identification of high-risk populations. Now the floor is open for questions.
Your patients that face of income, what was the level of CKD? Did you define at what level of PGF?
Yes, sir. I have included only stage 3 and stage 4 CKD patients. It was not the entire group. We chose this group mainly because the CVD prevalence or incidence of CVD actually happens after 2nd stage of CKD. So we particularly went in for CKD patients with stage 3A, 3B, and 4.
Okay.
Okay.
Stage 5 or end?
No, sir. End stage we didn't include, and EGFR more than the cutoff.
Yeah, association with 5 plus point.
Yes, sir.
But you said you had excluded diabetes.
Sir, actually, this is a part of my study, sir. I mainly work on miRNA for predicting cardiovascular risk in CKD patients. So for that, we wanted a proper miRNA selection. So we excluded all the confounding factors. So that is why we took age and gender match. And diabetes was like whichever would alter the expression of those miRNA levels, we actually kept it in an exclusion criteria.
Okay, so trying to imply whether your exclusion of diabetes was focused enough.
Sir, in this case, I'm not very sure, but for the main objective of my study, yes, it was needed, sir.
Correctly, you were able to explain that.
Ma'am, actually for controls, I had a problem. For patients, because patient details were available in the HIS, it was easy for me to see if they were already done. And one more thing, ma'am, in renal clinic, they usually do HbA1c in the initial screening. But for controls, it was difficult because when I took them and then I incidentally found that they were actually hyperglycemic, and those I had to exclude.
Right, yeah. I just wanted to ask, what is the criteria for selecting your controls?
Ma'am, basically they should not have, they should not be on any medication like thyroid, diabetes, even hypercholesterol.
Weakness control.
Okay, that was inside JIPMER, the crystal staffs I included. Ma'am. Mostly it was from the crystal staffs.
We just refined that CI phonicity index.
Okay, actually, phonicity index is the central adiposity measure that states the visceral fat distribution other than the generalized obesity. So it mainly concentration of the central obesity, which is the leading which can be more risk factor for disease, cardiovascular disease, and it uses mainly waist circumference, height, and weight for the calculation.
Show your exclusion criteria. Was there a dialysis situation?
Ma'am, that's what I didn't include any end stage patients. So usually after 50, yeah. Only 3 and 4 I've included.
Did any of them have arthritis?
No, that information I had not.
If they had arthritis, will it change your indices? Body rounded like index?
Yes, it might change.
Which would be a better way to find out the visceral fat rather than these measurements. Measurements are appropriate for a patient who doesn't have fluid retention, but probably a body composition analysis by EIA method or a DEXA can be better. Because they all will retain fluid, CKD and stage 4. They will also be on diuretics. So every time someone takes the diuretics, fluid level will come down. So there are some problems in this side, which you can take care of.
Yeah.
Thank you for the discussion. Move on the next presentation to stay on time. So breast cancer continues to be one of the most prevalent malignancies worldwide. Among its various subtypes, triple negative breast cancer poses particular challenges because it lacks hormone receptors and therefore has limited targeted treatment options. With this perspective, I invite our next presenter, Ms. C.R. Akshata from the Department of Medical Oncology, will present her work titled Identification of Differentially Expressed Genes and Dysregulated Molecular Pathways in Triple Negative Breast Cancer using RNA sequencing.
Good afternoon. My name is Akshata. I am PhD scholar from Department of Medical Oncology. Title of my study is Identification of Early Differentially Expressed Genes and Dysregulated Molecular Pathways in Non-Metastatic Triple Negative Breast Cancer using RNA sequencing. This study is ongoing and funded by ICMR. So triple negative breast cancer constitutes 20% of all the breast cancer, which is highly aggressive and high risk of visceral metastasis. So there is limited data which actually focuses on the immediate changes in the gene expression in response to small dose of chemotherapy, which could predict the tumor response in triple negative breast cancer patients. So studies focusing on early gene expression changes will aid us to understand chemosensitivity of the tumor, identifying non-responders and responders at the early stage, and tailoring the treatment. Personalized strategies may also act as a potential predictive biomarkers. So to study early gene expression, we used a window of opportunity design, which will help us to compare the tumor samples before and after the treatment, thereby helping us to identify DHEs and the altered pathways. So this study aimed to identify early differentially expressed genes and dysregulated molecular pathways in response to small dose of paclitaxel and carboplatin administered during window period in non-metastatic triple negative breast cancer using RNA sequencing. So this is clinical interventional biomarker study which uses window of opportunity design. Sample size is 38. We included newly diagnosed non-metastatic triple negative breast cancer with or without node positive among the age group between 18 to 70 who are planned for neoadjuvant chemotherapy. So window of opportunity design exploits the window period, which can be defined as the time gap between the cancer diagnosis and before starting the definitive treatment. So if any intervention is given during the window period, then it's window of opportunity study design. So screening and consenting will have done for non-metastatic triple negative breast cancer patients, and during baseline biopsy, bit of tissues were collected in RNA later, and for the analysis of RNA sequencing and gene expression. And during window period, patients received a weekly paclitaxel and carboplatin. On 14th day of receiving intervention, patient went for second biopsy, and bits of tissues were collected in RNA later for the analysis of RNA extraction and RNA sequencing. So patient further proceeded with the routine dose-dense neoadjuvant chemotherapy, which includes 3 cycles of EC and 4 cycles of DOSI every 2 weeks. And steady endpoint was assessed during the surgery. So now I am presenting only the early gene expressions. Gene expressions were not correlated with the steady endpoint, which is PCR. So RNA was extracted from fresh tissues, and purity and yield was checked by nanodrop and qubit, and visualized RNA integrity was checked by using gel electrophoresis. So we also analyzed the RNA integrity using bioanalyzer, which gives the RNA integrity score, and RNA integrity score more than or equal to 7 were selected for downstream analysis, that is library preparation and RNA sequencing. RNA sequencing, we used Illumina Nova 6000. Coming to the result, table shows the baseline demographic characteristics of 38 patients. Median age was 46. Predominantly premenopausal women were high. T status, T3 and T4 were equally distributed. N1 was predominant in the population, and majority of the patients underwent mastectomy. So moving on to the gene expression changes, we found 7 significantly upregulated genes in response to chemotherapy. They are involved in various pathways. Their upregulation favors the patients by suppressing invasion and tumor progression and enhancing the tumor immunity. We also found 4 downregulating genes. Suppressed expression of these genes may limit the tumor growth and metastasis. So all of these genes can potentially serve as a predictive biomarker in tumor response. So here volcano plot and the heat map is giving the visual representation of upregulation and downregulation of the genes. So red indicates the upregulated genes and blue indicates the downregulated genes. So both of the plots are clearly showing that a number of upregulated genes are more compared to downregulated genes. So Bushelos et al. In 2002 and Moldish et al. In 2004 have reported the early gene expression changes in breast cancer within 24 and 48 hours. But they were limited with a small sample size and included all the type of breast cancer. And few studies have also done early gene expression, which after the 3 to 4 cycles of the chemotherapy in breast cancer patients. Our window of opportunity design includes 38 patients and focusing only on triple negative breast cancer. And we also found significant transcriptomic changes within the 14 days. So to conclude, gene expression changes occurs very early during the chemotherapy and may serve as a predictive biomarker for the tumor response. Further integration with pathological outcomes is needed to confirm the predictive value, which will be explored in our future analysis. These are my references. Thank you.
Thank you for the clearly articulated presentation. We will now open the floor for the questions and comments from the audience. Dysregulated molecular pathways complex some particular pathway, like the upregulated and downregulated genes can be.
Yes, ma'am. Sure. So here there's the K gene C1, which is the mitotic motor. Downregulation of this, it actually leads to the mitotic catastrophe, which will ultimately lead to the cell death. And we have ELA VL2. This is actually stabilizes the oncogene mRNAs like cyclin and CMIC. So downregulating this will destabilize the oncogenic mRNAs and thereby again leading to cell death.
Synthesize this information from all of these.
Yes, ma'am. That is the further analysis. Yeah, that is the further analysis. Yes, ma'am. That we are working on it.
Similarly, maybe we have anything updated.
Yes, ma'am. There is gene called MIR4316. So this is involved in gene silencing. It actually inhibits the action of FOXP4, thereby decreasing the tumor cell proliferation. We have one more gene like ML3, so which is involved in calcium signaling, and that also involved in the tumor progression. All this gene expression is involved only. They have shown reported in breast cancer. They are not reported in the particularly.
Serial number represents the sample only number.
No,
Or the number of.
they're just number of genes.
You can try looking at the analysis. Yeah. Thank you.
What are the implications of these findings?
Sir, early, if we are able to predict early gene expression, which can predict the tumor response, we will be able to bifurcate, we will be able to identify who are the responders and who are the non-responders. Based on that, we can tailor the treatment and give the personalized treatment.
It was not done in your lab or it was outsourced?
It was outsourced. It was done in nuclear bioinformatics lab.
Analysis?
Analysis is going on, sir.
What
Bioinformatics
analysis will be done that you have done or that also was out?
bioinformatic analysis was outsourced. All other things are.
You have Indians very complex results.
Compared with the early gene expression changes, ma'am. I have not found Indian specifically.
Exactly. And be different for Indian. Thank you, Mr. Shapal. We move on to the next lesson, sir. In India, the National Program for Prevention and Control of Non-Communicable Diseases has introduced digital platforms to strengthen screening, patient tracking, and preventative care. With this in mind, I invite our next presenter, Ms. Directly Aurea Subramanian, from the Department of Preventive and Social Medicine, to present on determinants of adoption and utilization of the NPNCD digital ecosystem in Puducherry, a formative qualitative study.
Greetings everyone, I'm Jawaharlal Subramanian, PhD scholar working in ICMR 100 DigiCare NHRP project. I would like to kindly acknowledge my guide, Dr. Subita, and the whole team for their support. And today I am here on behalf of my team to present the formative findings of the study, determinants of adoption and utilization of NPNCD digital ecosystem in Puducherry. How to move to the next slide? So it's a moment for us to recall that the United Nations adopted the 2030 agenda to reduce the premature mortality from non-communicable diseases. So in 2010, India launched the NPNCD program, which is also called as the NPCD-CS program earlier. So as a part of this NPNCD program, India launched a national digital NCD ecosystem containing 6 applications, and this was very recently released in March 2024. So in this NCD national digital ecosystem, we have a total number of 6 applications. So ASHA uses which actually touches each level of continuum of care. So the ASHA uses CBAC app with for community-based assessment checklist for all the individuals 30 and above. ANM uses a screening app for early identification and referral of all the at-risk individuals. So this list of patients is actually generated by the CBAC score,
coming from the Asha app. So by now, it's very interesting that all these applications get synchronized at each levels. So the MO portal is being used by the SHC, PHC, and CHC MO for diagnosis confirmation, treatment initiation, control, referral, and follow-up. So this is at the facility side. In the program side, we have two portals which is being used. So the admin portal is being used by the admin to resolve issues at the facility side. So she's also responsible for facility mapping, transferring patients and beneficiaries. The health official dashboard is being used by the state program officer for his administrative oversight. So all this data from the ASHA ANM MO admin gets accumulated and synchronized monthly to the state program officer dashboard for his administrative oversight. So despite this structured design, system effectiveness depends upon the system usability. So we are actually aiming to develop a digital health model for sustained adoption and utilization of the NPNC digital ecosystem, and this is a multi-centric implementation research project. The objective of our formative phase was to explore the determinants of sustained adoption and utilization of the national NCD digital ecosystem. So here's how we did it. It's an implementation research study which I mentioned earlier, and it's a qualitative study. The sampling frame consists of one district hospital, two community health centers, 32 PHCs and 56 subcenters. So we used case deviant sampling to analyze the ANM screening percentage of all the facilities, and then we categorize them into moderately performing and good performing facilities. And geographical distribution also was taken into account to ensure maximum variation and representation. And the final sample size was 22 facilities, as you can see. Then the eligibility criteria is facilities implementing the NPNC portal. And on the participant side, we actually did 43 in-depth interviews. The 43 was taken from to give clarity. We interviewed MOs from PHC and CHC and ASHA ANM MOs from SHCs. So we also additionally interviewed 4 state officials. And the participant eligibility criteria is to have at least 3 months experience in using the NPNC portal, and the app should be downloaded and having login credentials. So going deeper into the data analysis part, 43 interviews were transcribed and uploaded in the NDO 15 silver implementation framework. Consolidated framework for implementation research was actually used, and it was the heart of the analysis. So all the transcripts were uploaded, and each sentence fragments which gives an evidence of being a barrier or facilitator to the NPNCD digital ecosystem was coded under each super construct. It was categorized into barriers and facilitators, and all this information was then moved into a coding matrix where we used a balance framework to do the ratings according, and the scale as has been shown. So this is the definition we sticked upon. Innovation is the NPNCD, inner setting is the facilities, is where the NPNCD is implemented. Outer setting would be the Puducherry health system. Individuals would be the people who are receiving it, delivering it, and leading it. And implementation process is the activities used to implement the innovation. So the most awaited part, the results. So after CIFR-based analysis, we found that the inner setting was actually predominantly affected due to work infrastructure. So MOs and ANMs are describing it as they are managing 475 patients in 6 hours, and patients have to wait at each and every place, and patients are not ready to wait for another line for the separate portal entry. And ANMs are also describing that they have overlapping program activities every day, and they are also not free to do it. In contrast, ASHAs have raised one point that they are able to rectify issues at the facility side to the admin whenever they have login issues. So next, the second domain, which is innovation. Constructs such as system complexity and relative advantage were strong barriers. So this is actually hindered by a point, there is no unique identifier. So duplicates are a major concern in the system. MOs, ASHAs, ANMs, all the 3 carriers are explaining that they have 10 entries in the same day. Patients are not giving their own number. There is no unique identifier. I don't know which patient I entered today, and I forgot to take the same patient tomorrow. So these are some of the points they are describing. And when it was naturally discussed with the state officials, we found that duplicates are caused due to a mass enrollment drive which happened 3 to 4 years ago. And some of the reasons also could be incentive-driven behavior. And the state program official is also not in a place to delete all the records and concerned that the portal numbers would get down. So there are also certain points that MOs are relatively dependent on manual records because up referral, down referral systems are not following it. And Asha has raised one point that she is very happy with the functionality of Asha app due to the offline features. So, design limitations were also raised. The MOs are not able to see how many CBAT Asha have completed and all, and there are also buffering glitches, mornings are around 10 auto loggers seen in the system, and the MO is also not able to edit and delete the records. So she is feeling helpless when she saw a humongous data on her system and she is not able to correct that. And the dashboard is also not useful for the monthly reporting because ANMs are sticking to old forms, NP, NC, HWC reporting forms, and reported statistics is not useful to fill the forms. The SPO is facilitating NP-NCD as a related priority. So MOs are describing getting insisted on doing daily, monthly, and cumulative counts by March 31st or December 31st. But and they are talking about the 2 minutes. May I take some time? Really time down, so you have to finish within very quickly. I'll try. Yeah. Okay. So. But the state official is actually describing that he is actually finding an overestimation in the CBAT numbers, but when it comes to follow up and actual control rates, only a tip of the iceberg has been presented. So there is also confusion in roles and responsibilities among ANM, and incentives is being seen as a motivating factor among the ASHAs. And despite all of these barriers, a good practices has been observed in the system. So if the system did not completely collapse to zero despite all this barrier. So MOs are actually practicing total data entry of NCD clinic days. They are dedicating tasks to the interns, and they are also practicing post-clinic batch entry using NCD cards and NCD clinic images. And they are using this NCD cards for also identifying missed follow-ups. So this is the conclusion of the study. Finally, what do my verbatim tell? It's not about digital reluctance, it's about digital misalignment. And now we are actually moving to the co-designing phase where we are designing solutions that are not only technology sound, but workflow aligned and practically usable. Thank you so much. Any questions? So this is also some portal statistics you can refer to based on my qualitative findings. You can see high enrollment numbers, lack of duplicate identifiers, and small number of people being under treatment.
From the way I'm not sure if the end user priorities were taken into consideration, the total functionalities were designed. It's like some portal was there, it was given and say you force feed the data. So then that will result in all types of wrong entries being made just to fulfill the requirement rather than let the end user sees the merit or sees the purpose in using a particular device. If I use a pen, I should know why it is useful to me. Similarly, whatever be the device, I couldn't see that NP NCD is forced from somebody. It is forced fed on the worker. I did not, when you say determinants of option, more than a question, I would like you to suggestion that you go back to your field and try to find if the end user derive any benefit at each level. You have medical officers, you have ASHA workers, you have multiple levels of field workers. So do they see any merit or value in entering the data in the portal? So that will help identifying the need to enter the data in the portal. Otherwise, the data will be trapped.
I completely agree, sir. Thank you so much.
There is one question from the audience. Can somebody give the mic to sir?
It was the reason actually the study was needed consequently work for our kind workers after because for all the programs we have complete work from after. So what would be like one thing that you explore for a testing based by after. So the whole that study will be done further in way and so from this point of time, what will be your suggestion to the policy?
My suggestion to the policymakers would be, so right now duplicates are a major concern. So it's not my suggestion, but my team's suggestion is to redesign solutions to make sure that this duplicates is not a major concern in future. And this is happening through implementing our ideas in the portal for each and every patient. Thank you so much.
Among the PF,
Yes, ma'am.
among the PFs which you have looked at, which were, you had one which was very performing very well, from DBM selections you had, right?
Yes, ma'am.
One which were performing well. Do you find anything extra in the industry in which the MO also was comfortable and so now it looks like the MO is uncomfortable and the ASHA is not.
Yes.
So the very well performing PHC, was there any different input you got?
Yes, ma'am. We actually got different inputs from the well-performing facilities. So the last second slide, which I was presenting, adapting NCD cards, so that they're not able to do it real time, but they're keeping the cards for their records, so that after the patient goes, they are saving the card and entering in the portal. At least their portal is reflecting accurate data and not fake data. So that could be some good practices the MO is following. And he is also following color-coded treatment cards based on villages so that it doesn't get confused with the other portion of people. And they are also using the cards to track the missed follow-up for patients. So slowly when they start using these cards, it might help for real-time entry also.
What do you make me duplicate?
What, sir, the duplicate entries means one patient have 5 or 6 health records by being the same patient actually. So these duplicate entries are due to duplicate visits conducted by the ASHAs, and every time the patient changes his phone number, another record has been made under his name, and the family folder is also confused. So one patient having 5 or 6 records, and every single detail is the same. So that is the duplicate.
We will have to call the discussion here due to time constraints. So moving on to thank you so much, Ilakya, for the nice presentation. Moving on to the next presentation, occupational health hazards are often underrecognized in informal sector occupations, despite the significant physical demands placed on workers in these environments. Assessing muscle strength and hand function to tools such as hand grip and finger pinch dynamometry provides useful insight into ergonomic stress and occupational health stress. With this background, I invite our next presenter, Ms. Vishnupriya here to present her study titled Ergonomic Risk Assessment using Hand Grip and Finger Pinch Dynamometry among 2 informal occupation groups in Puducherry city. Ms. Vishnupriya, ma'am, please begin.
Thank you. Good afternoon, all. Today, the topic of my presentation is ergonomic risk assessment, and this is carried out in various occupational settings. And we have chosen 2 groups in the informal sector. So a little bit of a little bit about the introduction background. So as we carry out our manual task day to day, we experience a stress on our musculoskeletal system. In occupational scenario, repetitive tasks, pushing, pulling, lifting, all of these exert a massive strain on the musculoskeletal system. And there is a decline in functional capacity as the years of service. They force themselves. I have chosen informal sector precisely because they are totally unaware of the health problems they are going to face. They think they are all age related, but we are going to see that by looking at dynamometry recording of hand and a finger pinch strength, we show that there is an accelerated decline due to occupational ergonomic strain, which is a continuous throughout their job. So these are my objectives. So hand grip and fingertip strength using the dynamometers. And the second objective is to examine age stratified deficits. Now, age stratified deficits with respect to the normal population. Normal population, we have a range, normal, weak, and strong. And we are looking at the deficit percentage, which occurs due to the occupational exposures. Now, these are the methods and material. It's a cross-sectional study, part of my PhD, and has the IEC approval. These are the equipments used. They are standard equipments, excellent in reliability, used in various field exposures, especially in India. So we have these two study participant groups. One is the municipal garbage collectors and the other is welders. The municipal garbage collectors has both females and males. Welders, there are only males. And about the sampling, this is a standard sampling strategy followed for dynamometry. We have 3 records of each hand. We take the average and use it for analysis. What is the analysis we do? Paired t-test to compare left and right hand, and also intra-class correlation coefficient in order to test the reliability of our data. So this is a violin plot. You can see the contour of the violin plot. It shows the spread of the data. So you can see the males have a greater spread of data. Here, the embedded box and the jitter gives you that there is no clustering in the females. They are more centered around the mean. Whereas these are more spread out. You have more outliers in the male. This is for finger pinch and this for hand grip. Now, looking at the descriptive data, again, this is just a backup of that figure. I have highlighted the max and the min values of hand grip left and hand grip right. And you can see for both males and females, there is a large range, which shows that despite of different age classes, we are having a very wide distribution. So this is for the finger pinch. The same thing. We have min and max highlighted. Now, to look at the statistics of the welders. Here also we see min and max is again the spread of the data is 2.04 to 6.88 in the finger pinch, and hand grip. Oh, I have put here. So 20.57 and 75.47. Here, the important part is that you don't see much of variation within the group. Yeah, this is visually appealing. You can see that males of 2 groups. We have the males of the group A in the orange, and then the dark maroon is group B. They are welders. We expect that they have greater economic strain, but then you see this is above this, and this dip across this age group in the finger pinch of group A. Here also you have hand grip of group A and somewhat, steady values for group for the hand grip. This we are comparing the males only of the 2 groups. So these are the normative values that we get along with the dynamometers, and we use these to. This is for the baseline pinch, and that is for the hand grip dynamometer. This is the way we have calculated the deficit. This is standard. We take the normal average, we subtract the observed from that, divide and multiply by 100 to get the deficit percentage. I was curious to know how far the decline went. So we took the weak threshold. You can see the weak threshold. We took the weak threshold values and we calculated deficit from that. So we got a D2 from that. And to my rude surprise, I found that the salmon pink, they're all D2. Right across the various age groups, you find there is a great deficit. These are percentages. You can see this mustard is only the high values I have put for D1. Similarly, for finger pinch, you see again, finger pinch is for finer movements, as you can see. And here also you find there are high deficits in the older people. The older people are expected to have some decline, but we are talking here beyond the weak threshold of the normal values. So this is for the welders. Again, you see D2 values are covering almost all the age. So imagine in the age of 30 to 34 itself, you find there is a 10-11% of deficit. This man is going to continuously work. What happens when he's 50 years old? So this is the importance of monitoring ergonomic assessment. We have to integrate this with other assessments in order to give a picture of the decline in functional deficit, in decline in functional capacity. So the paired t-test give you significant for the left-right differences for finger pinch in the group A. For female, for males, there is no difference. Group B, both hand grip and finger pinch are significant. So intra-class correlation gave us excellent results, meaning that our data collection is reliable. And the conclusion, you see, this I have verbatim taken from our standard. Yeah, verbatim taken from the reference, while this they have taken from a very large group. They have conducted the study. So they say that while this declines with age, sustained occupational physical exposures and repetitive task demands, they contribute to greater functional deficits, which are expected from physiological aging, which are more than what you expect from physiological aging alone. So that then we, what do we suggest is routine finger pinch and hand grip so that we are able to detect, evaluate the risk, and introduce intervention programs. So these are the strengths and limitations. This is my cross-sectional study, so we can't have causal inference. So we need longitudinal setting of different occupational groups. These are the references, my acknowledgement to my guide, to my funding agency, PhD colleagues, field assistants. Thanks. I hope I bring some change into the quality of life of my participants. And thank the Office of Dean Research and reviews of the scientific committee. And thank you, my colleagues and audience.
Thank you for
This is for all. This is for everybody. Healthy workplace is a productive workplace, and it's for every occupation, every human being, both physical and mental. Thank you.
Thanks for the engaging and informative presentation. We will now open the floor for the questions and comments from the audience. Firstly, that the reason for decline is not in occupation, but that nutritional status being poor, or many of them might be uncommon disease. So that those also get attributed.
Yes, that is there for all human beings. Yes. So when we're doing this study, first we are looking at decline. And once we are highlighting the medium and high risk, we start exploring further. We start looking what is the reason. But first of all, we need data. This is only a beginning. We are going to follow up with a whole lot of, and especially the study design. We need longitudinal data. The plus factor is that we have the reliability, excellent reliability of the. So our sampling strategy is correct, solid. Yes, that we have to explore.
And then the group had a distribution which was very unique.
Yes.
Did you try to find out?
Yes. You find the these occupations, the males in the garbage collectors, they have the hand and the left hand and the right hand are both used equally, lifting the bins, carrying, pushing, and all that. Whereas the welders, one hand is constant. So you can see right hand having more deficit. You see in the welders group. whereas it's not so much in the males of the group A. Occupational task, yes. Occupational task is what I am exploring and trying to investigate. What are the job tasks which cause cumulative ergonomic strain? So these are other, we have to integrate with other ergonomic assessments like posture. We have to do ruler EBA, which is upper limb assessment. The weights. Yes, sir.
You have lots of data, but while presented, we cannot see the difference, the right hand and left hand for the middle.
So I've been practicing and not coming up with the time, and so I'll be very happy to share. Thank you, sir.
My question, do we have intervention for them?
Yes, this is follow-up. The risk groups, as usual, we will put them in low, medium, and high risk. The high risk group we have in occupational interventions itself, we have like a priority list. First, the job, the worst ones will have a job change. We advise job change. We don't want them to do that repetitive task. We try to, with informal sector, we are having a very difficult time. The same thing with formal sector industry. Their problem is only absenteeism. They have economic costs. These fellows, they will come, but in informal sector, you don't come, you have no salary. So there is a lot of difficulty in getting them to comply. And
Thank you, Mr. Shubhra. Next one, thanks. To the other presenter. While advances in cancer treatment have improved survival outcomes, treatment abandonment remains a major challenge, particularly in the social setting. I invite the next presenter, Dr. Reshma, to present on co-designing multi-level interventions to reduce treatment abandonment in cancer care, a partisan implementation approach. We apologize for the delay. The presentation will begin in a second.
Good afternoon, everyone. Today, I'm presenting our work titled Co-Designing Multi-Level Intervention to Reduce Treatment Abandonment in Cancer Care, a Participatory Implementation Risk Approach. This is a part of an ICMR-funded study. So continuity of care is essential for the successful cancer treatment. However, treatment abandonment remains a major challenge in cancer care, especially in low and middle income countries. Because it results in poor outcomes and wastage of resources. Because of the complex nature of the treatment abandonment and the multifactorial involvement, traditional top-down approaches fails to identify the barriers faced by the patients at real-world setting. So if we use co-design approach, it enables us to integrate the patient, provider, and system perspectives, and also to develop practical and sustainable intervention. With this rationale, our study objective was to develop a multi-level intervention package to reduce treatment abandonment in cancer care using a co-design approach. This is the overall study design. The intervention development usually starts with formative research to understand the barriers and enablers faced by the patients. So, but in this presentation, I will be focusing more on the co-designing approach. So, multiple barriers to continuation of cancer care were identified through formative research and were categorized under patient level, family level, community level, and health system level. And when for the co-designing process, thus we conducted it in 4 phases, which was guided by the UK Medical Research Council framework for development of complex intervention. So in the phase 1, stakeholder engagement and consensus building on the contextually relevant intervention strategies were conducted with the involvement of 14 stakeholders. And in phase 2, we prioritized the intervention strategies identified in phase 1 using an impact feasibility metric, and 10 stakeholders were involved in this phase. And in phase 3, the intervention strategies were again refined and categorized across various levels. And in phase 4, we prioritized all these strategies based on impact, feasibility, and scalability. So at the end of phase 1, we identified almost 27 strategies under 7 categories. But practically, it is difficult to implement all these strategies. So we, in the second phase, we evaluated all these intervention strategies individually using different criteria such as impact, feasibility, acceptability, scalability, equity, strength of mechanism, measurability, etc., with the score ranging from 1 to 3. So based on this research, based on this priority scores, again we refined these 27 strategies and reduced that to 19 strategies under 3 domains like patient and caregiver supporting strategies, community level strategies, provider and system level strategies. Even then also, implementing all these strategies are very, practically it is not possible in resource constrained settings. So we wanted to identify the strategies with high priority. So here in the x-axis, it is feasibility score, and in the y-axis, it is impact score. Then the bubble, which is at the right upper quadrant, is the highest priority strategy for reducing treatment abandonment. So here we got at the patient and caregiver supporting strategies, we got the highest priority one as baseline distress screening and need assessment and tailored counseling for the patients and caregivers, followed by the peer support group. And at the provider and system level strategies, the highest priority ones were strengthening the navigation, financial support system, and providing the clear information of treatment at the baseline, followed by establishing treatment abandonment as a key priority, key performance indicator, symptom management helpline, better communication strategies, followed by electronic tracking system and token system. And at the community level, awareness campaigns were the highest priority ones. So all these strategies, we put up all these strategies into a logic model. This is the structured pathway, which shows how these strategies, using these strategies, we can achieve long-term impact. So here inputs, activities are there, outputs are there, and outcomes also we can divide that into short-term, intermediate, and long-term outcome. So this helps to visually identify the strategies, and we can learn how it is leading to make the health impacts. We can learn that process. So treatment abandonment is influenced by multiple interacting barriers. Although multiple studies have described the determinants of treatment abandonment, evidence on multi-level intervention strategies to reduce treatment abandonment remains limited. So we are addressing this gap by using stakeholder-driven co-design approach and develop a context-specific intervention package. This approach aligns with the emerging implementation science framework that emphasizes participatory design or co-design for complex health system challenges. Also, this model provides a structured and scalable framework to reduce treatment abandonment in resource-constrained settings. So, to way forward, pilot implementation and evaluation of the intervention to assess its feasibility, effectiveness, and potential for scale-up.
Thank you, Dr. Reshma. The floor is yours for your question.
Actually, we enrolled the newly diagnosed cases at the baseline, and we followed up them for 6 months. So during the 6 months, if they are not coming for treatment, if it is for more than 4 weeks, that will be considered as treatment abandonment as per the standard guidelines. So then we conducted qualitative interviews among patients who abandoned treatment, their caregivers, and patients who completed treatment without any interruption to understand their barriers and enablers.
Short cancer treatment.
But ma'am, as per the literature, like if there is that 4 weeks of gap in the first 6 months of treatment, that can have adverse effect in the treatment outcomes. That's what literature says.
Any particular type of cancer?
Yes. I was focusing more on 7 common solid tumors like breast, cervix, ovary, head and neck, lung, stomach, colorectal. Solid tumors. Adult patients.
You have designed which are the most common factors that led to this?
Actually, main thing was at different level, different factors are there. But patients like one is low health literacy is there when it comes to patient level, and they have a lot of financial challenges not related to treatment but indirect cost associated with treatment and non-medical cost also. And also there are a lot of system related constraints like poor communication, language barriers, and navigation is not proper. So they don't have clear idea about their treatment, like the treatment continue and they are not aware.
The data that you expected basically focused on communication issues and could you come out with any strategy to improve on that?
That's what, sir.
The overall thing, the final message that I could get was communication was a major.
Yes, sir. So next phase, that's what we designed when we are focusing mainly for communication-based multi-level intervention packages. So
patients want to know what is the severity of their disease, prognosis, whether they are getting the right diagnosis, management. So there is no one to answer the question, probably because of the load or communication language barrier.
Yes, sir. Even like they don't know when to come. Actually, they don't have clear idea about treatment. Like when they are shifting from one department to other, also they are
treat results with some other historical control, say from a corporate hospital where the load of the patient to doctor will be different.
Yeah.
Trying to understand.
Actually, we didn't study like that, but in the beginning, we conducted healthcare workers like we included healthcare workers across India from high burden centers, including public, private, semi-private, all the settings. So what I heard from oncologists is that in private corporate settings, this abandonment is very low. Like they are shifting from one hospital to another. Like after completing one modality of treatment, financially they will be affected, so they will go to government hospital. That kind of scenario is there, but abandonment aspects is very less in private hospitals.
The studies are echoing the findings across India, which you have similar findings or
No, actually, there are studies in pediatric population, multiple studies are there, but in adult population, we could not find any this kind of studies. Yes.
What's the framework based on which you have done this? Is a UK based.
UK based to develop.
And be validated to our setting.
It is like universally we are following that for the development of complex interventions. Like it is just for
complex.
Yes. No. Like there are 4 phases of development. That's.
Thank you so much for the discussion. So now we'll move on to the Milligan Award presentation, which recognizes outstanding research contributions presented during JIPMER Research Day. We have 2 speakers presenting for the session. These presentations will also follow the same format of 7 minutes for presentation, followed by 3 minutes for questions from the audience. Our first presentation under the Milligan Award category focuses on exploring the potential therapeutic effects of natural compounds in cancer research. I invite Anuja Anandraj from the Department of Pharmacology, present on cytotoxic and pro-apoptotic effects of curcumin and vitamin in human non-Hodgkin lymphoma cell line therapies and dendritic cells.
So, a very good evening, dignitaries and colleagues. Myself, Anuja Anandraj, PhD scholar from Department of Clinical Pharmacology. So, I'll be presenting a part of my thesis titled Cytotoxic and Pro-Apoptotic Effects of Curcumin and Vitamin D in Non-Hodgkin's Lymphoma Cell Line. It's basically a cell culture study. So, the work has been recently published as well in the PubMed Index journal. So, scenario pick to understand the study as such. Testing a drug on cultured cells is like training a defense force to eliminate harmful cancer cells before deploying it to protect the entire human system. So with this understanding, my study's rationale is that non-Hodgkin's lymphoma is a highly aggressive subset of B-cell lymphoma. And as a category of cancer, so we have chemotherapy as the first line regimen. So as we all know, so there are plethora of, the chemotherapy as such is coupled with the side effects and adverse events and as well as resistance. So this prompts the interest for safer alternatives. And that's where the natural compounds like curcumin and vitamin D are into play. So we have lots of evidences for curcumin and vitamin D, but the research lacuna is that whether the combination also, when it is given in combination also, they work well. So whether they have synergistic or the antagonistic or additive effect. So what happens when given in combination was the research gap which we found. And that's what this study tries to address as well. So with this, the objectives of the study is to evaluate the monotherapy as well as the combination effect of curcumin and vitamin D for the cytotoxicity in LBCL, in the DODY cell line. And also to address the combination as well as the monotherapy on pro-apoptotic effect. So moving further, being a cell culture study, so there are 4 parameters which we have to address, that is culturing of cells, and the viability check by cytotoxicity, and the apoptotic check is done by nuclear staining, that is a visually we check if apoptosis has happened or not, and the molecular level check by means of gene expression, that is qPCR. So following this cell culture, the DODY lines were procured from a national repository, and then based on the culture conditions, the media and the cell density which has been recommended, so the cells have been cultured. Simultaneously, the test drugs curcumin and vitamin D have been prepared at various doses, the various narrow and the wide range doses. And for the viability check, under which we identify the IC50 dose of curcumin and vitamin D, the MTT assay, the standard assay is what we follow. So where we seeded the cells of recommended density, and then we tested on different doses, by different doses of drugs were tested on the wells, and then the incubation based, 24-hour treatment window. Following that, the cytotoxic testing reagent entity was added to it. And after 4 hours of dark incubation, a solubilizing agent was added to it to visualize the output of the MTT assay, which is in terms of color intensity, the purple formation. So more the intensity of purple color is directly proportional to the viability of the cells. That is what we interpret by means of MTT assay. So that is basically a cytotoxic assay which gives the percent viability of the cells at the end of this assay. So moving further is for the apoptosis, to check whether the cells have undergone apoptosis. We are going for visual check as well as the molecular level check. So for the visual check is the nuclear staining, where we use DAPI, which stains the nucleus. So if the nucleus is undamaged, that is in case of untreated control, so the nucleus is condensed. But in case of the treated cells, the nucleus appears to be fragmented. And that is the interpretation for nuclear staining assay. And this is the overall protocol workflow for doing a nuclear staining assay using DAPI. And fragmented or irregularly stained nuclei is the output of for any treated cells. And moving further, so after we visualize the apoptosis by nuclear staining, we want to prove it at the molecular level as well. And that is where we did gene expression for a panel of apoptotic, pro-apoptotic, and cascade genes. And these, again, this is the protocol which we follow for gene expression and RNA expression, RNA isolated from treated, untreated cells. And following that, we had RT-PCR for gene expression analysis. And these are the panel of genes which we explored, the anti-apoptotic, pro-apoptotic, and the cascade genes, and with an internal control, GAPDH. The statistics for data representation is mean and SD. And for comparison across various groups, we did ANOVA followed by post-hoc analysis. And it was done using GraphPad, and p-value less than 0.05 was considered to be statistically significant. So based on the methods which we followed, the results are by MTT assay, that is the cytotoxic assay. We found that curcumin had an IC50 dose of 1.6 micromolar, and vitamin D had an IC50 dose of 50 micromolar. So whether in combination, what was the dose? So in combination, curcumin dose was reduced to 0.5, and the IC25 dose of vitamin D was found to be 7.5, and this combination was found to be synergistic because they had a combination index of less than 1, which is 0.8. So with this, this is a cytotoxic assay which gave us the viability reports with IC50 doses. So moving further with the staining of apoptosis, we found that the untreated cells, the nucleus is intact, whereas in case of treated cells like curcumin, vitamin D, and the combination, we have nucleus that is fragmented. So that is a condensed or fragmented nuclei indicating of apoptosis. So this is a visual check where it has qualified the apoptosis process. So this, after indication of visually understanding apoptosis, the molecular level, the gene expression level. So we discussed, as mentioned before, we had a list of genes that we had studied. So for curcumin, to understand the pathway, apoptotic pathway, which apoptotic pathway it follows, intrinsic or extrinsic. So we had, curcumin treated cells, they had high expression of caspase 8, which is an indication of extrinsic pathway. And in case of vitamin D, this caspase 9, it was upregulated, in indication of intrinsic pathway. When given in combination, again caspase 9, again the intrinsic pathway. So by the end of gene expression, we could conclude that curcumin follows the extrinsic and vitamin D and combination follows the intrinsic, that is the mitochondrial pathway. So the key findings of the present study is that curcumin and vitamin D, both monotherapy as in combination, they exert cytotoxic as well as the pro-apoptotic effects when given in combination. So they have a synergistic effect because of combination index less than 1. So they could regulate the pro-apoptotic and the cell cycle regulatory genes, especially when given in combination. The P21 and P53 have been upregulated. And these natural compounds, so in future, they could be used as chemosensitizers. So to minimize the toxicity of the frontline chemotherapy agents. So at the outset, the study is a kind of golden alliance where the king of the universe meets the king of spices, so that that brings up a radiant synergy in cancer sciences. So thank you so much, and these are my references and acknowledgement, and thanks so much.
Thank you, Nicole. Enjoy your great production. So the dose of protein, how did you select that?
We initially started with wide range of doses, and then we narrowed down to the narrow range of doses, and with the previous literature support, we fixed to the IC50 dose. The 50% dose at which the viability of the cells are compared to untreated control cells. That is the same protocol we follow for vitamin D as well. But in combination, we found that we fix dose of one drug and we vary the dose of the other drug. Likewise, we do vice versa for the other combination as well.
In the real life situation, where do you get this combination from? Where you get in a natural real time situation in life? How do you get these two together? D3 and protein.
D3 is highlight. And curcumin is a dietary supplement. Yes.
You had both singly and then combination, is that right?
Yes.
In the cell lines?
Yes.
In case of having any thing where you are adding agent
A positive control.
yes,
Yes. No.
because you are feeling that it is helping in the
Yes. Because
it will override the
definitely in future it will validate our study. For now, we didn't include because we had an internal negative control and it's a mechanistic study. So we thought this would suffice for mechanistic study. Further validation, when we go for protein validation, which is actually validation which we have to add, we can look for adding a chemotherapy agent as a positive control to our studies.
We will reduce body cell lines. They are very aggressive on the perfect lymphoma. We have used curcumin and vitamin D3. Executing upper course of and the cytotoxic effects of these two compounds.
Yes.
It's unless you compare with some other agents and see the difference in the apoptotic or cytotoxic effect between other standard agents in comparison with solution.
That was actually definitely a limitation. We couldn't have a standard in our study because earlier it was planned as an exploratory study where we try to understand what is happening. It's a continuation of a clinical trial. So here we try to understand the mechanism of what is happening to the drugs.
Even rapidly dividing cell line,
Definitely.
was there any damage, internal damage due to passages?
We
Could you
maintained
standardize the or validate the?
Yes, sir. The passage number was maintained the same throughout the study. Whatever the passage number was maintained from 5 to 10. The same was maintained for gene expression as well as for the
Before
well.
administering or exposing curcumin and vitamin D3, could you check the viability of your cell line?
Viability check. So before treatment, yes, sir, we did the viability check and then cell counting by cell chemocytometer and then we had it.
Thank you so much for the discussion. Now moving on to the last presentation of this session. Gestational weight gain is an important determinant of maternal and neonatal health outcomes. Understanding its relationship with adverse pregnancy outcomes can help guide antenatal care strategies and improve maternal health programs. With this background, I invite our next presenter, Dr. Namita Patel, will present the study titled Gestational Weight Gain and Adverse Pregnancy Outcomes with pregnant women attending primary health centers in Puducherry. Please, ma'am.
Good afternoon, everyone. My name is Dr. Namita Patel, and today I will be presenting part of my PhD research work titled Gestational Weight Gain and Adverse Pregnancy Outcomes Among Pregnant Women Attending Primary Health Centers in Puducherry, results from the JIPMER Pregnancy Cohort. This study is published in Indian, it is under production in Indian Journal of Medical Research. Gestational weight gain is an important indicator for maternal and fetal health being during the pregnancy. It has already been shown in the studies that excessive gestational weight gain is associated with an increased risk of GDM, high blood pressure, preterm birth, C-sections, LGA infants, and infant mortality. Insufficient gestational weight gain is associated with intrauterine growth retardation, low birth weight, and SGA infants. Currently, we have for gestational weight gain standards, US recommendation guidelines, IOM guidelines, which is based on the US population. However, for Indian or other LMICs, there are no specific gestational weight gains being followed or being established. Evidence also suggests that women in Sub-Saharan Africa and South Asia achieve less than 60% of the recommended minimum gestational weight gain. With this rationale in our mind, we framed our objectives as among pregnant women registered for seeking care at selected rural and urban primary health centers, Puducherry, to estimate the proportion of inadequate and excessive gestational weight gain and identify the factors associated with gestational weight gain, and to also study the association between gestational weight gain and adverse pregnancy outcomes. So this is a part of a JIPMER cohort study, and we have followed prospective cohort study design. We recruited participants from urban and rural primary health centers, Puducherry. A woman coming for antenatal care and within less than 14 weeks of gestation were eligible for the inclusion, and women with overt diabetes or hypertension, under medication, pre-pregnancy, and who were willing to migrate outside Puducherry after delivery were excluded from the study. The study duration was from May 2022 to April 23, and total of 465 women were enrolled into the cohort. Initially, we have enrolled at the baseline 465 pregnant women. Till delivery, we followed up 408 women, and rest of the were lost to follow-up. And after delivery postpartum, 386 women were followed up for the postpartum and outcomes of the delivery. Ethics, JIPMER scientific and ethic approval was sought from the JIPMER. Data was collected on socio-demographic characteristics, maternal anthropometry, and pregnancy outcomes. We calculated gestational age based on LMP and also confirmed from ultrasound done before 20 weeks of gestation. Gestational weight gain was calculated weight which was recorded just prior to delivery, subtracted from pre-pregnancy weight. Excessive gestational weight gain was calculated based on the IOM recommendations, and IOM recommend based on different BMI categories. So for the normal weight, the recommended weight gain is between 11 to 16 kg. We followed standard tools to collect the data for our study. Data was entered into Epidata software and was analyzed using Strata version 17. Gestational weight gain was summarized as into three categories: inadequate, adequate, and excessive. And we reported a percentage with 95% CI. To find the factors associated with gestational weight gain, we ran multivariable linear regression and we reported adjusted beta coefficient with 95% CI. Also, to find the factors, to find the association of gestational weight gain with outcomes, neonatal and maternal outcomes, we did log binomial regression and reported adjusted RR with 95% CI. Coming to results, the mean age in my study, the mean age of maternal age was 26.4 years. Around 71% belong to urban population, and education for around 70% of the population was above graduation and higher. Majority, 65% came from joint family, and also majority of the population came from middle socioeconomic status. These are the main findings of my study. As per IOM, we have divided this, and we found that inadequate gestational weight gain was among 48% of the women, and excessive was among 19% of the women. The mean gestational weight gain in my study was 10 kgs with a median of 9.9 kgs. And we also found that as the pre-pregnancy BMI or the BMI was increasing, the mean gestational weight gain decreased. Excessive gestational weight gain was positively correlated with higher waist circumference, this body fat percentage, and higher body mass index. At the baseline, 70% of the women were physically inactive, less than 600 meds. And the carbohydrate, protein, and fat intake and the energy intake was comparable between all the three categories, and there was no significant difference. When we did a multivariable regression, we found that joint family, women coming from a joint family, women belonging from a lower socioeconomic status and nulliparous have higher gestational weight gain, and also higher pre-pregnancy BMI has a lower gestational weight gain. These were the factors found out significantly associated. These are the pregnancy complications and adverse outcomes. We found that 17% of the women had GDM, and C-section was in 39% of the women, low birth weight 24%, and SGA 27.2%. When we ran a log binomial regression to find out the association of gestational weight gain with outcomes, we did not find a significant difference. However, some outcomes were commonly associated with excessive gestational weight gain, like NICU, admissions, and low birth weight. So the mean weight in our study was 10.1 kg. SRMA, which was done among Indian studies, have reported almost a similar mean. However, there were other cohorts which we have compared with. Revamp cohort has a little bit higher mean gestational weight gain, and Garbhini cohort, on the other hand, is a lower gestational weight gain. This difference was found because the population and the education status and the socioeconomic status was different in both the in other cohorts. Inadequate and excessive gestational weight gain proportions were comparable when we compared with other cohorts across India. The major strength of my study is a prospective cohort design. So we have collected the weight at each antenatal visit. So this is the main that it reduces the recall and misclassification bias. And we have included participants from both urban and rural PHCs. However, the participants seeking the women seeking treatment from private clinics were not included. So this is a limitation. Also, the before pregnancy weight or early pregnancy weight was used as a proxy for preconception weight. We cannot rely on the weight which participant will report. So that's why the first weight less than 14 weeks was considered as a preconception weight. So this is a limitation. And dietary and physical activity was recorded at baseline. So this could not be recorded throughout the pregnancy. So changes was not assessed during this throughout the pregnancy. Conclusion. Nearly half of the pregnant women experience inadequate gestational weight gain, and we found that joint family, lower socioeconomic status, nulliparous, and higher pre-pregnancy BMI were significant predictors of gestational weight gain. The recommendation which I want to give from my study findings are strengthening the RMNCH program and inclusion of routine antenatal care, regular weight monitoring, counseling on a healthy diet, and staying physically active. The one rationale with which we have established our study is there are no Indian-based guidelines or even guidelines for low income countries, Southeast Asian region, and WHO and ICMR called for data while this project was ongoing, and I'm happy to share that our JIPMER cohort has been selected at both global and national level to share the data for the development of guidelines. And also we have already signed the agreement with World Health Organization, shared the data. ICMR, the process is still going on. All the steps were taken after seeking permission from Institutional Ethics Committee and JIPMER. I want to acknowledge all the participants and my doctoral committee members and co-guides and Department of PSM, also JIPMER for funding it for the project. Thank you everyone for your kind attention.
Thank you for the insightful and well-presented study. We'll now open the floor for the questions from the audience.
Thank you. What was the JIPMER cohort? Can you give some details about?
Ma'am, JIPMER cohort, So the full form of JIPMER cohort is Journey of Pregnancy Through Adiposity, Nutrition Status, Maternal Neonatal Outcomes, After Birth Weight and Metabolic Shift. So this cohort is a cohort of 465 women which we have enrolled at less than 14 weeks.
The cohort is primarily your study cohort.
Yes, ma'am. This is my study cohort, and this is a part of the study. Actually, we have also a component of postpartum weight retention and some cardiometabolic markers which we have assessed till 1 year postpartum. So this is still the pregnancy which I have presented, part of my PhD work.
The outcomes are not different. Maybe people who have low weight gain and
no, ma'am. The reason probably is the main the sample size was calculated based on the other primary outcome. These association of gestational weight with outcome was not our primary outcome, so that's why the sample size is not sufficient to pick up that difference. But the significant difference was not observed.
The four factors that you mentioned were common for both low gestational.
No, sir. We ran a linear regression. The outcome was continuous variable, gestational weight gain. So the nulliparity, joint family, and lower socioeconomic status, these factors were for higher gestational weight gain. And pre-pregnancy body mass index, at the lower pre-pregnancy body mass index, higher gestational weight gain. It was associated negatively. So 4 factors.
this is in management here.
I have a question regarding me, which is a very interesting idea. So I wanted to know your baseline was that you don't know what is adequate weight gain in Indian, right?
Yes.
So then why did you choose to classify based on what was given as adequate and inadequate instead of maybe you could have done tertiles and said the lowest weight gaining versus the highest weight gaining? What is the difference between the two? Are they associated with outcomes? Did you do that?
I did not do that, ma'am. The main thing why we are classified as per IUM right now, because all the cohorts in India and international cohorts are following this guidelines for now. But since the guidelines are coming up, like WHO is working, so I think it will change. I did not do with the quartile. It's a good suggestion, ma'am. I can try with that also to find any significant difference if that exists.
Maybe that is the reason why we are not seeing this patient.
Yeah, correct.
Thank you, Dr. Namita, for your presentation.
Thank you. Thank you, everyone.
All the work presented today reflects the dedication and scientific resolve of PhD scholars contributing to advancing knowledge and improving healthcare. With this, we conclude the PhD scholar session of JIPMER Research Day. The next session will feature presentation from senior essays. Thank you all for your participation.
Minutes. Thank you.
registrars. To begin with this session, I would like to invite the moderators, Dr. Anaga, Department of Pediatrics, Dr. Bisman Singh, Department of Pediatrics, Dr. Sriram Reddy, Department of General Medicine.
I would like to introduce the judges for us for SR presentations. Dr. Srijit Parameshwaran from the Department of Nephrology, Dr. Anusha Cherian from the Department of Anesthesia and Critical Care, Dr. Ravi Philip Rajkumar from the Department of Psychiatry, Dr. Raja J. Selvaraj from the Department of Cardiology, and Dr. Pradeep Nair from the Department of Neurology. Thank you.
Good evening, everyone. We shall now start with the senior resident oral presentation. This session will highlight the diverse research contributions from our senior residents from various subspecialties. Each presenter will have 7 minutes to the presentation, with a time allowed given at 5 minutes and a final allowed given at 7 minutes, followed by 3 minutes for discussion. Professor Formula, neurology SR, present a study that is transcranial direct current stimulation as an adjunctive therapy for functional dissociative seizures and randomized control trial.
Second one.
Good evening, everyone. I'm Dr. Soumya, Senior Resident, Department of Neurology. I will be presenting my research title, Adjunct PCS for Functional Dissociative Seizures, a randomized double-blind sham control trial. So, patients with functional dissociative seizures, they have epilepsy-like events, but without abnormal electrical activity in the brain. So, it remains a challenging clinical entity without effective pharmacological therapies. So, here comes neuromodulation to bridge this therapeutic gap. So, neuromodulation techniques show small to moderate effect sizes in other neuropsychiatric conditions, suggesting potential applicability for FDS. Despite this theoretical promise, we do not have prior RCTs for TDCS, especially for FDS patients. So, with that rationale, we did a study in patients with functional dissociative seizures with more than or equal to 2 events per month. The intervention arm received active TDCS, the comparator arm received sham stimulation. The primary outcomes that we looked at were 50% event reduction at the end of first month. The secondary outcomes we had looked at were event reduction at the end of second and third month, safety and adverse events, and quality of life parameters. We had followed up the patients for a time frame of 3 months. So ours was a single center, double-blind sham-controlled RCT. The randomization was done in 1:1 allocation, done using permitted block randomization with using variable block sizes of 2, 4, and 6. The randomization sequences were generated through online portal, and it was carried out through opaque sealed envelopes to ensure allocation concealment. Our study was approved by the ethics committee and registered in the with the Clinical Trials Registry of India. We had received intramural grant for this study. So when we did our study, they were in prior RCTs using TDCS for FDS patients. So we had looked at a study which used RTMS. Based on that, we assumed that the active arm would have a 70% response. The sham would have a 10% response. So the absolute risk difference is 60%. We calculated the requirement of 15 per arm to achieve a power of 90% and 0.05 alpha. After adjusting for 20% dropout, sample size we finally achieved was 36 with 18 patients in each arm. So we included patients with video EEG confirmed functional dissociative seizure with more than or equal to 2 events per month. The electrode placement was same for both the groups. The anode, the active electrode, was placed in the right temporoparietal junction and cathode was placed in the left supraorbital region. The active group received a treatment protocol of 2 milliamperes, 20 minutes duration, 2 sessions per day for a total of 5 days, adding up to 10 sessions. The comparator arm receives sham stimulation, that is, the electrodes and everything will be placed similarly, but they will only get an initial ramp up and ramp down for a few seconds. They will not get the actual current stimulation, and both the groups receive multidisciplinary care. So this is the TDCS apparatus, the sponge electrodes, and here we can see that this is placed on a patient, the active in the right temporoparietal junction and the cathode in the left supraorbital region. So after the application, we would apply an adverse events questionnaire for the patient to quantify and characterize the adverse events that the patient experienced.
So the enrollment was done from Jan December 2024. We had seen 101 patients, 65 were excluded due to various reasons, and 36 patients were randomized. We did an intention to treat analysis. 17 patients were analyzed in the active arm and 18 patients in the sham group. One patient lost to follow-up in the active arm, and one patient was excluded from the active arm due to protocol deviation. So the baseline characteristics were comparable between both the groups. Our study group mainly comprised of young females, and pseudosyncope was the most common event type, which is very much similar to the details published in the previous studies. So we had also collected baseline details like medication history and psychiatric scores and quality of life parameters like HAM-A, HAM-D, WHO, BREF, and Poly31. All these were also comparable between the groups. So at the end of 1 month, both the groups had improved significantly. 17 patients in the active group and 16 patients in the sham group had achieved more than 50% event reduction, and 14 patients in the sham and the active group and 11 patients in the sham group were event free at the end of 1 month. Though these numbers were not big enough to create a statistically significant difference, the active group was doing better than the sham group, at least number-wise. So even at the end of 3 months, the active group had achieved 100% patients in the active group had achieved more than 50% event reduction, and 88.9% patients in the sham group had achieved more than 50% event reduction. This consistent trend favors active TDCS in sustained remission. So while looking at other outcome parameters like anxiety, depression, and quality of life scores, we were able to see a very similar trend. Both the groups had improved across the 3 months time period, and the active group was consistently doing better than the sham group. So there were no serious adverse events. Headache was the most common side effect noted. That was also comparable between the groups. It was slightly more in the sham group, in fact, and it was overall well tolerated. So going on to the discussion, I would like to stress that both the groups had improved very well, and this is due to the high quality multidisciplinary care provided to all the patients. And the active group had a consistent numerical advantage over the sham. And this positive effect that we were seeing was not at any given time point alone, but it was present throughout the 3-month follow-up period. The magnitude of effect that we were seeing was small, but this is consistent with the broader neuromodulation literature. So these findings suggest a likely adjunct role for TDCS rather than a functional standalone cure. So our study was the first RCT of TDCS in functional dissociative seizure. It is a well-designed double-blind sham-controlled study with a well-characterized video EEG confirmed cohort of patients. And we provided standard multidisciplinary care management to these patients. We had a longer follow-up duration of 3 months. And we had looked at patient-reported outcomes like quality of life. So these would be the strength of our study. Our study does have few limitations like the smaller sample size and the confounding effect of the multidisciplinary care and concomitant medications. And we have relied on self-reported event diaries. So that could also be one limitation. So to conclude, I would like to conclude by saying that TDCS was found to be safe and well tolerated in this functional dissociative seizure patients. And we demonstrated sustained improvement. This highlights the importance of structured care, and the consistent trend favoring active stimulation highlights the possible role for TDCS as an add-on therapeutic modality for these patients. And these results support the need for further evaluation in larger adequately powered multi-center trials. Thank you. We always organize for sharing your executive research. The floor is now open for discussion.
Thank you, Mr. Sorry. Congratulations on this work. I have just one important question. Which is, you assumed that there was going to be a 70% response rate with the active treatment and 10%. Now, non-epileptic attacks, you would have worked with them for years. You know that there's a very strong element of suggestibility. Yes. And where there is suggestibility, there's also going to be a very high placebo response. Yes. So are we justified in assuming that there will be a 70% response rate to the active treatment? But only 70% may be correct, but can you assume that there will be a 10% response rate? Whereas we know that in many patients with a non-epileptic attack, the placebo response is quite high. It's 40 to 50% or more, though it is not well sustained.
Our assumptions were based on a non-randomized studies with the RTMS. So there the effect size was
RTMS in non-epileptic attacks.
Non-epileptic attacks. So there the effect size was much larger. So
But there are, but you get these response rates from that study, 70% and
Actually, at the end of 1 month, 100% patients had received a 50% seizure reduction, and four patients were completely event free in that study. It was done with 7 patients.
was there a control group?
No control group in that study.
Thank you.
If this definition was wrong, how do you deal with that?
That issue. Assumption for the sample calculation was that there is 70% different, but when you are finding this practically not different, then how do you deal with that situation?
That is one of the limitations that we have listed, sir.
You are telling there is no legal better size. What does it mean?
Maybe if the larger sample size, maybe we could demonstrate a more significant difference.
Why do you think let's go arm also for this?
So this is a well-known fact with functional dissociative seizures, sir. So they are likely to respond to.
We will now like to invite Dr. Ritesh Kumar Mishra from Immunology to present his study titled Predictors of Early Renal Response and Long-Term Outcomes following rituximab in relapsed and refractory lupus nephritis.
Good afternoon, everyone. I'll be presenting our study on predictors of early renal response and long-term outcomes following rituximab therapy in a cohort of relapsed and refractory lupus nephritis. So, in SLE, kidney is the major organ involved, which determines the prognosis in a SLE patient. It occurs in about 50% of cases of SLE, but around only 30 to 50% of them will achieve CR with the usual therapies, cyclophosphamide, MMF, and steroids. And around 14 to 33%, depending on the definition and the cohort, around 14 to 33% will have a refractory LN. And the risk of ESRD is around 5 to 30% at 10 years of diagnosis. And rituximab, though it has failed in the RCTs, it is widely used as a rescue therapy in refractory lupus nephritis, mainly derived from the supporting evidence from the observational studies. But they will have a limited long-term follow-up. Meta-analysis data has shown to be less responsive in the Asian cohorts compared to the Hispanics and the Caucasians. So the Caucasians will have a better response. And the larger data from Indian cohorts in refractory lupus nephritis is limited. Hence, we conducted this study. Our main objective was to look at the short-term renal outcomes and the long-term renal and patient outcomes, and also the safety of rituximab in relapsed or refractory LN, and also to identify the predictors of short and long-term outcomes. It was a retrospective study design. The data was collected from the department records of difficult to treat LN. Patients who had received rituximab induction and had a refractory or relapsed biopsy-proven lupus nephritis were taken, and this would have a minimum follow-up duration of 6 months after the last rituximab induction. The definitions were as per the EULAR, ERA, EDTA, partial response with more than 50% response in proteinuria and achieving a subnephrotic range proteinuria with a near normal GFR. Complete response means a less than 0.5 gram per 24 hours proteinuria, and no response doesn't fulfill either PR or CRR. Refractory also by similar EULAR definitions, failure to improve within 3 to 4 months, failure to achieve PR within 6 to 12 months, and failure to achieve CR within 2 years. And relapse means a patient who had achieved a sustained PR and has relapsed with worsening proteinuria or renal functions. Data was collected for all the variables, demographic, clinical, histopath. Renal outcomes were measured at 6 months for all the patients and at 12-24 months where the data was applicable, and provided the patient did not switch to other therapies. Long-term outcomes were seen in form of CKD or mortality. This was evaluated for all the patients. CKD being defined by the usual definition of less than 60 ml per minute for more than 3 months. Stats was continuous variable was analyzed using Mann-Whitney, categorical using Fisher-Exact or chi-square, and predictors were analyzed using univariable analysis. Coming to the results, so if you look at, we had 79 patients of relapsed or refractory lupus nephritis in the cohort who received rituximab induction at day 0 and day 14 of 1 gram. And at 6 months, if you see CR rates being around 37%, PRR rates being around 31%. So giving a sum of around response rates of around 70% in the refractory group. So keeping in mind, these patients are really refractory and had failed 2 induction therapies beforehand. So getting a 70% response rate is also a significant number. Non-responders were 1/3. And if we see at 12 months, so those who continued maintenance rituximab, they had a sustained response of around all of the patients had a sustained CRR. Those who did not even receive a maintenance rituximab, they continued to have CRR at 1 year. And in PRR group, all the PRR achieved CRR at 1 year. And even non-responders, around 6 patients, so around 1/3, 25% of the patients attained some response at 1 year. And similar, this CRR or PRR rates kept on increasing on 2-year follow-up also. And if you look at the long-term follow-up, median of 3 years follow-up of refractory LN, CRR at 6 months group, they had a less number of composite CKD plus mortality, only 2 patients compared to 5 patients in the PRR group. Compared to NR group, if you look, mortality and CKD composite outcome was 11. So significant number difference was there. And if you look at predictors of CRR, there was no significant difference in age, sex, or lupus nephritis duration. Definitely a higher nephrotic range proteinuria and low serum albumin predicted non-attainment of CRR at 6 months. Baseline kidney dysfunction there was no difference between it. Class 5 LN, none of the patients attained CRR at 6 months. Apart from that, other activity score, chronicity score, having crescentic GN did not affect CRR rates. And if you look at the treatment history, cumulative dose of cyclophosphamide given didn't differ. Number of induction therapies, median were 2 and comparable in all the 3 groups. And concomitant immunosuppression given with rituximab, usually in our group, in our cohort would be MMF. There was no significant difference. And if we look at overall median follow-up of around 3 years, long-term renal outcomes was predominantly decided by the 6 months response group. So if you look at the numbers in the non-responder group, 45% of them had a composite of CKD or mortality on the long-term follow-up of 35 months. And so on analysis of these long-term outcomes, non-attainment of any response at 6 months or at least a CRR by 1 year had a significant higher risk of composite outcome of CKD or mortality on a long-term follow-up. If you look at the adverse events on rituximab, predominantly infection was the main adverse event noted. Around 21% of them had a major infection, and mortality was 10 out of the 79 patients who had received rituximab, and all of them had some kind of infection. 9 had both flare plus a infection along with them. Neutropenia was seen in 2 and major infusion reaction in 1. So concluding my study, at 6 months, CR or PR rates cumulative would be around 70%, and non-responders were around 30%. CR increased at 12 and 24 months among those who maintained on rituximab. Baseline nephrotic syndrome and a class 5 LN predicted failure of early response, and the non-response at 6 months identified a high-risk subgroup with significantly higher CKD and mortality rates. And infection definitely remains a major contributor in Indian settings due to adverse outcomes. Thank you.
Thank you, Dr. Ritesh. We can now begin question.
You have controlled patients who had relapsing lupus as well as refractory. You look at the disease process, these are not same, right? Refractory is different and relapsing lupus refractory are different. So what is the logic behind coupling these two people together?
Basically, sir, they had all failed 2 lines of induction therapy. So we had given them
the relapsing person was resistant and then was given rituximab or what?
Relapsing person
different from resistant, no?
Yes, sir. Relapsing person means he had responded to a therapy and had gone into remission, but again had a relapse. Refractory
activation is different from resistant lupus, and the response, the outcome, long term are all different between these 2 groups. That's why I'm asking why did you decide to club these 2 groups? Because they are not comparable.
Yes, sir. But actually, what we found here was there was no difference actually between the 2 groups. So relapse and refractory, they had a similar kind of response to rituximab on a long-term outcome also.
So and the relapse, you gave only rituximab or there was some other treatment?
Sir, around 80% of them were on MMF also.
What about refractory? They were refractory. What was the treatment? In addition to rituximab, what did they get?
Majority of them, along with rituximab, because it has failed in RCTs, we always add a second-line agent, MMF or tacrolimus. or azathioprine, depending on the scenario. But some patients we did not give due to higher infection risk at baseline. So for them, we just give rituximab.
So the background therapy was not comparable, no?
Yes, sir.
You also mentioned interestingly about the switch people who were switched to an alternate therapy were excluded from the long-term analysis. Does that mean that a patient was on rituximab who needed to be switched to under treatment for whatever reason was excluded from the long-term analysis?
So basically, these were those patients of non-responders for whom we changed the treatment completely. We stopped rituximab and gave a different line of therapy for them.
So they were not considered for further.
For long-term outcome analysis. So till the last visit only, till the 6 months only, we took their findings, not for the long-term analysis.
Yeah, but that will improve the outcomes anyway, right? We are taking out the bad people.
Yeah. That definitely is.
Did you look at the CD19? Did you see rituximab? Did it prove depletion of B cell system? Do you have data on?
Sir, we did not do the 6 monthly B cell depletion. We usually do a IG profile, and if IG is normal, we go ahead with second maintenance dose of rituximab. So we did not do it was a prospective study. So
you gave two injections followed by 6 months. After that, yes, you are not given the repeat.
yes, sir. We were maintaining them, sir. At like 24 months also, some people had received rituximab. So we were giving them 6 months rituximab.
So how many?
Sir, the numbers exactly.
What is your short-term and long-term definition? What is short-term? 3 months is short-term.
No, sir, 6 months. At 6 months. PR and PR. Long-term is a CKD or mortality at the last visit.
So I call upon our next presenter, Dr. Ismail from the Department of Preventive and Social Medicine. His study cited patient patterns and determinants of antenatal care utilization in Indian research, a secondary analysis of NFHS 5.
Good evening. Am I audible? Yes, okay, thank you. So, good evening, I'm Dr. Ismail, and my topic is spatial patterns and determinants of antenatal care utilization in Indian districts, secondary analysis of NFHS 5, done under the guidance of Dr. Subita, Dr. James from the Department of PSM. My SR ID is 10. Coming to the background, for India to achieve its maternal targets with respect to Sustainable Development Goals or National Health Policy 2017, antenatal coverage is an important aspect. So in the antenatal coverage, the number of antenatal visits is an equally important indicator, which is for service utilization and for continuity of maternal care in India. WHO has moved on from minimum of 4 to 8 visits, but there are many districts in the nation which are still lagging behind with respect to this minimum number of 4 visits. So hence we wanted to try to find out which are these districts which are underperforming or overperforming, and are they clustering together? What are the factors associated with these performance at the national level and at the regional level as well, so that targeted interventions can be planned by the government of India. Hence, our objective was to assess the spatial distribution and determinants of antenatal care visits at the district level among women aged 15 to 49 years residing in India using the NFHS 5, the 2019-2021 data. This data set is publicly available but should be accessed with prior permission from the DHS, which was obtained. And we took the individual level data of the women aged 15 to 49 who having a birth the last 5 years, but we aggregated all of these data at the district level. So we used an ecological approach, and then we did the entire analysis at the district level rather than the individual level. Our outcome variable was what are the districts having the proportion of women with at least 4 ANC visits was the outcome variable. And the independent variables were selected used by the Anderson healthcare utilization model, which delineates population level characteristics, health behavior, health outcomes, etc. So you can see few of the variables which have been listed. We also tried to take whether there was any media exposure and women empowerment variables as well. And we tried to cluster certain variables which showed us perceived barriers with respect to healthcare access and combined them and made a composite indicator and included that in the model. So this was the barrier index, which was made from the variables of the NFHS. Either there is difficulty in permission to go to the visit, or there is no money to go, or there is the distance is more, or there is difficulty in transport. What exactly is the difficulty? Those were captured and then they were made into an index and included into the model as well. In order to see whether there is clustering of the outcome variable of interest, that is ANC4 proportion, we use the global Moran side. But at the national level, clustering is not enough. We want to know where exactly is the clustering. For that, we use the local Morans or the local indicator of spatial analysis, which gives certain hotspots, certain cold spots. Hotspots as in the districts which are performing well, and cold spots which are lagging behind. We use spatial regression in order to make sure we try to find the effect of the predictors on the outcome, accounting for the spatial dependence and also adjusting for the spatial dependence. Hence, there are 2-3 models of regression which we usually take in spatial regression. We use R and Geoda for our analysis. Coming to the results, at the national level, 58.4% of the women have at least 4 ANC visits. Here you can see the map of India showing district level proportions of at least minimum of 4 ANC visits. So the lighter blue ones are those which are underperforming. The darker blue ones are those which are performing fine. Here you can see some form of clustering occurring of the lighter districts here and darker districts there. But this is subjective. We need to be objective, and hence we go ahead with the global Moran's I index to see if the national level there is clustering, and value is more than 1, which means there is clustering occurring and it's significant. So we try to see exactly where exactly is the clustering happening and try to find out the hotspot and the cold spot areas. So using Lisa analysis, we found the dark red are the ones which are better performing districts, and the blue ones are the underperforming districts. And hence, and then we proceeded to see what are the variables which affect this ANC proportion. So basic logistic regression was run, but the problem with this is it assumes each district is independent. But how can you see if there are 10 medical colleges in Pondi, the benefits is not restricted only to Pondi, it's also seen in the neighboring districts of Tamil Nadu. Hence, we went ahead with spatial regression models, and we saw that women with higher education, working women, rich households, and people having health insurance, all of them had higher ANC coverage, whereas those which had barriers to access healthcare had lower coverage. And overall, you can see around 38% of this effect was diffuse, which means the ANC proportion in my district is getting affected around 40% by the ANC coverage in the neighboring districts. So this is an important finding from the study as well. So coming to the implications of the same, we know that these are the variables which are known before as well, known to affect ANC4. But all of those have assumed independent district and they have not taken into account the spillover effects. So this study tries to delineate the exact coefficients which takes into account the spatial noise and the spatial dependence and gives more precise estimates. Not only that, it tries to identify those districts which are underperforming and those districts which are overperforming and what are the reasons that could be associated with the same. And some of the recommendations which comes from the study is right now we are focusing on aspirational districts program. This study shows that not only aspirational district, but it's an aspirational cluster district which has to be focused, so that instead of making district program implementation plan, we need to make those cluster districts program implementation plan, because we see here the health effects seem to spill over from one place to the other. So the strength is nationally representative data, use spatial analysis. Limitation is there is ecological fallacy, which means the association which I do at the cluster level does not hold true at the district level, at the individual level. And there are certain key variables which have not been included because the NFHS does not capture those variables. For example, the health facility, the staff density, etc. Fine. These are my references. I'd like to thank my professor in the department for guiding me and making sure I'm able to proceed with the work. Thank you.
For your insightful presentation. We can now have questions from the judges and audience. How many districts were included?
707 districts as per the NFHS file during that time. Right now there are more districts, but during that time it was 700.
So the picture that you showed, so it could be that some of the districts are not.
There is no data for the same. For example, the northmost part is undefined. We don't have data for the same, and we can't interpret this for us.
So you put the coloring.
Coloring is much. We apologize for the same. It's misleading.
And you also showed that various factors that the woman is not going to
Yes.
So did you analyze those with them?
Yes, ma'am.
And what is the?
So after making an index, after combining all of these barriers, we can see here the health system barrier index is showing a negative association, which means for every increase in the number of barriers, there is a proportionate decrease around 2% in ANC4 plus proportion. Meaning if the barriers increase in a district, then the proportion of ANC4 plus visits decreases.
So all the districts are recording these?
Yes.
From each?
From every single district data is there.
I think you already know that southern states are better off with antenatal care. So you have not documented it. So how does it help? Don't we already know that the antenatal care is better in some states compared to the others?
Yes, sir. Now, more than the states, we are now focusing towards the district level so that within the districts, within the states, we have inter-district variation. Some districts are performing well, some are performing poor. So planning for the entire state as a whole will be challenging. So we have to go as low as possible. So this study tries to delineate, ignoring the state boundaries, it's within the districts and if these districts are clustered together or not. So right now, the administration is district level. We have to move from this district level and see nearby districts also how to plan together so that the economy and etc. All of them are saved. There is no repetition of efforts. That's the intention of this. So, and these are the variables which have an effect. Initially, these were the estimates, but after accounting for the spatial association, these are the revised estimates, which are more correct, or I would say a more unbiased estimate compared to the previous literature.
With your previous question, can you just go back to that film? When you expect Kerala to be a top state with the annual care, so why that area is not going to cluster?
There is clustering, sir. In Kerala, this is red. Red indicates high hotspot.
Kerala, the major part of the Kerala.
This one. So this red shows that this clustering as a whole has to be seen. So if there is clustering of the neighboring districts, only then it pops up. If the nearby districts is underperforming, then those areas of Kerala are not highlighted. Only those areas of Kerala are touched where there is 2, 3, 5, 4, 6 districts together, which is having high proportion.
This survey, 80 level survey, or it includes the private attendance also?
It includes the private, it includes at the individual level they go, but it's a sample. It works on a sample, but it's not on all the people. It works on a sample, but it goes up to the household level, even in the individual level as well.
Small question.
Could you find any association between the family, that is the average number of children per woman, and any of these variables related to the district level?
This is
a lot of the things you mentioned, maternal age, higher education, working women. These are also predictors of the reduced total number of children. And when you have less children, you tend to invest more resources in them. You're more motivated to go for regular checkups, to take more health care. So do you think that could be a confounding there? That it's not just a direct effect of being more educated and all that, but that's also an indirect effect of having fewer children and therefore being able to proportion resources out better.
Yes, absolutely. This is a key variable which had to be included. The birth order or the parity itself would have slightly affected the model as a whole. I agree. The point well taken, sir.
Thank you. We now invite Dr. Dharani Rattan. Right, there's one question from the audience. Sorry for keeping you on. I just have a question for you. For all of these so-called that you have used to explain the subject, so did you see whether these factors that you are taking, they themselves are clustered?
Yes, ma'am. All of these effect of these factors clustering is adjusted in these spatial regression models where, as you rightly say, these factors themselves have a clustering effect. So education and other health infrastructure, for example, in Pondi, the health infrastructure in Pondi is affecting the neighboring districts. So that has been covered in the spatial lag model. And here you can see 38% of the outcome is because of the neighboring clustering and the neighboring outcomes. So that is what is, yes.
Thank you.
Thank you. Thank you.
Thank you. We now invite Dr. Dharani Pratap from Surgical Oncology to present the study titled Structured Prophylactic Program for the Prevention of Lymphedema Following Breast Cancer Surgery, a randomized control trial.
Very good evening to all. Myself, Dr. Dharani Pratap from Department of Surgical Oncology, presenting our study on effect of structured combination program of prophylactic compression sleep along with lymphedema education and specialized post-operative exercise rehabilitation on post-axillary dissection short-term lymphedema among the patients who are undergoing surgery for breast cancer, a randomized control trial. The Globocon 2022 data shows the breast cancer is the second most common malignancy in women and the fourth leading cause of cancer-related mortality worldwide. And in India, the overall 5-year survival being 80% and the 10-year overall survival being 65%. The management of axillary part is the cornerstone of operable breast cancer, and the most common being performed surgery is the axillary lymph node dissection. Carries a significant risk of irreversible upper limb lymphedema, which will adversely affect the quality of life as well as the upper limb function. So our randomized control trial evaluated whether the structured preventive strategy combining this prophylactic sleep, lymphedema education, as well as the specialized post-operative exercise reduces the early lymphedema at 6 months following axillary lymph node dissection. So our primary objective is to evaluate whether the structured combination program reduces the ALND at short term. Our secondary objectives are to compare the upper limb functional outcomes on the side of surgery between the standard as well as the routine postoperative care groups. So the methodology, our study being a phase 3 randomized control trial, unblinded parallel group and the superiority design conducted between the July 2023 to December 2024, approved by the IEC as well as registered in CTRI, randomized into 1:1, and the arms are intervention arm where they are receiving the structured combination program, and the control arm they will receive the standard post-operative care. The inclusion criteria histologically confirmed stage 1 to 3 breast cancer, underwent axillary lymph node dissection as a part of surgical management. The exclusion criteria were male breast cancers, bilateral breast cancer, previous history of any surgeries involving the upper limb, and the patients only undergoing sentinel lymph node biopsy were the exclusion criteria. So we calculated with the superiority study design with the assumption the difference will be 15%. The final sample size is 262 participants, being 131 in each group. The methods, the participants recruited at the time of hospital admission, and the baseline socio-demographic, pre-operative and intraoperative variables were recorded. The post-operative assessments being done in 1, 3rd and 6th month. The participants in the intervention arm can withdraw at any point of time. So the interventions done in both the groups, in the intervention arm, the structured program group, where they will receive the compression therapy, which consists of a class 1 compression stocking. The pressure is 15 to 21 millimeters of mercury, which will be initiated on the post-operative day 1. And the sleeves has been worn during daytime for 8 to 10 hours daily for 6 months. And the education will be provided regarding the proper usage and washing and replacement. And we'll be also providing a lymphedema education booklet, which will be in both English as well as in local language, explaining the risk of lymphedema and how to prevent and the precaution. And also the post-operative exercise rehabilitation, which will be done by the PMI department in the post-operative day 1, and which will be supervised at day 1, week 2, and monthly for the 6 months. Then also it will be ensuring the adherence to the exercise protocols, and also will be asked to document the adherence. The control arm, which will be receiving the standard post-operative care, which will be initially supervised by an instructor, which will include the shoulder range of movements and combining with the deep diaphragmatic exercises. And we are advising to do this exercise 15 minutes for daily. So our outcome measures is the primary outcome being the lymphedema assessment, which will be assessed. That it is defined as the relative arm volume increase, which is more than or equal to 10% on the side of surgery. And the gradings as given as per mild, moderate, and severe. Mild is less than 20%, moderate is 20 to 40, and severe is more than 40. And the functional assessments has been assessed using 2 scores. One is the DASH score, and the second will be the hand grip strength, which will be used as a handle dynamometer. So this is our consort diagram. Finally, 289 patients were assessed for the eligibility. Finally, 262 patients were randomized, 131 in each group. This is our pre-operative and intraoperative characteristics. All the variables were comparable between both the groups. The most common age group being 40 to 60 years in both the groups, and the median BMI is 24.7 in control group and 25 in intervention group. The other parameters like receptor status, tumor grade, as well as the stages were comparable. And the most common stage being is the stage 3B, so the locally advanced, following this stage 2B. And the intraoperative details were comparable, and only a less number of population received level 3 axillary lymph node dissection, around 19% in each group. The other parameters like number of lymph node harvested and the post-operative histopathological variables were similar. So our assessment, the lymphedema incidence at 1 month is totally 9 patients. At 3 months, it is 18 patients. At 6 months, it is 22 patients overall. And it is similar between both the arms, as well the intervention as well as the control arm. The secondary objective, the functional outcomes, using this DASH score as well as this hand grip strength, we use this both the analysis per protocol as well as intention to treat analysis, and all the secondary outcomes were also similar between both the groups. So the six month incidence of lymphedema following ALND, whether in MRM as well as BCS, it's being 8.4% in our study group, and most of the patients were in mild category only, which is more than 90%. And the post-operative DASH scores as well as this hand grip strength remained largely unchanged. The structured combination program did not significantly reduce the early onset lymphedema or the functional outcomes as compared to the routine care. And in our study, the incidence is almost similar to the previous studies done by various studies. And the previous evidence for this prevention program is heterogeneous. Some studies showing the benefit, which is some large randomized control studies did not show any difference. The most common reason being they quoted as a poor adherence to the exercise program. But in our study, we are our adherence rate was more than 95%, and also the attrition rate is only 5%. So the current evidence suggests the most common consistent risk factors for development of lymphedema being body mass, high body mass index, and the surgical site infection. Our strengths are like objective volume measurements, standardized definitions, and the rigorous follow-up. However, we didn't target the high-risk populations like patients who are having high BMI and patients who exclusively underwent this level 3 axillary lymph node dissection and patients who received irradiation. So our trial showed that the structured combination program did not have an additional effect of early onset lymphedema prevention following ALND compared to the patients who received the standard post-operative care. And further, in our study, the patients developed only a minimal upper limb as well as shoulder morbidity. Thank you.
Thank you, Dr. Jawaharlal. We now invite questions from the judges and audience.
The consumption of sample size calculation was how much percentage each?
The 15% reduction, sir, based on some
15% reduction.
Yes, sir.
What in the control and what in
the patients who received the structured combination program, we thought that the lymphedema incidence will be reduced to 15% as compared.
Okay, is it 50-25 or 65-50?
You expect what the baseline incidence of?
So baseline incidence is around 10%. So we expected 15% reduction in that.
10%, how do you take it? From 10%.
The overall incidence of lymphedema is 10%, sir. Like in early onset, like 6 months. The previous studies which showed that
the basic problem that you yourself said that in your study you got only 8%.
Yes.
Overall. Okay, so from that, if you are thinking, even if you are taking 15%, so the other group will be 0%.
Yes.
So I think the assumption for sample size calculation is a little bit, maybe you should have taken one of the right? Okay. And then usually you don't express p-values for baseline parameters in RCT. Okay. You don't put that good.
You said that attrition was low in this one.
Yes.
Only 5%. So when you say attrition, you mean people who dropped out of this.
Yes, sir.
But did you have any measure of whether the people were actually wearing the stocking or no? Because attrition is one measure of adherence. But another measure is whether the person actually cooperates with the treatment or the exercise during the course of those 6 months. You may have been able to supervise it, immediately after surgery in the hospital. But at home, we don't really have a good way of monitoring. So how sure are you that they cooperated or that they stopped wearing the sleeve on their arm for 6 months continuous, which most of us would not.
Yes, sir. That is being the most of the patients who complain wearing the sleeve throughout the day, almost 8 to 10 hours. They have that minimal discomfort as well as the social, like wearing the sleeves when going outside. But since we educated the patient the importance of this, and many patients adhere to the protocols.
How many? If you ask them, like in the last 1 month, how many days did you wear? Or in the last 1 week, how many days did you wear?
So, most of them like only 6 days they wear, sir. That during that weekends they have some poor adherence to that wearing the sleeves.
In the 6 days, do you think they were just being polite and telling the doctor what does the doctor expect?
Yes, sir. We are asking this. It may be subjective, sir, but we're not very sure about.
With the family member.
Yes, sir. Attendance during the assessments we are asking, but still sometimes the majority of the patients are old age and they are like staying independently. So we're not sure like whether they are adhering or not. But what the patient said, we are taking into account.
When they stay alone again, that is yet another risk
Yes,
factor around it.
Yes.
For the next presentation, I invite
On position, continuing with the sample is calculated. Rightly, there is a error in terms of calculation. You can report the power and recalculate the power.
Taken, so thank you.
for the input. For the next presentation, we would like to invite Dr. Manjunath from the Department of Endocrinology to present a study titled Skeletal and Renal Changes in Chronic Post-Surgical Hypoparathyroidism, a cross-sectional analytical study.
This is next. Good evening, everyone. I am Dr. Manjunath Totaganti. I am a senior resident from the Department of Endocrinology. Today, I will be presenting skeletal and renal changes in chronic post-surgical hypoparathyroid patients. It was the cross-sectional analytical study. So, post-surgical chronic hypoparathyroidism is defined as persistently low serum calcium with low or inappropriately normal PTH hormones, at least after 6 months of surgery. So, most of the patients are treated with conventional therapy. That means they are being supplemented with calcium and activated vitamin D to alleviate the symptoms of hypocalcemia. So, conventionally treated, these patients are prone for low bone turnover states and hypercalciuria. So, there is a conflicting data on the effect of hypoparathyroidism on bone quality and fracture rate. So, in this study, we are comparing the bone mineral density and trabecular bone score between the chronic post-surgical hypopara patients and apparently healthy controls. And the secondary outcomes were to compare the morphometric fractures and bone turnover markers between these patients and normal patients, and to estimate the prevalence of nephrocalcinosis and renal dysfunction in these patients who are on conventional therapy. So it's a cross-sectional study done in the Department of Endocrinology from July 2022 to May 2024. The group 1 is a post-surgical hypopara patients. The inclusion criteria were the patients aged 18 to 60 who have underwent surgery and diagnosed as hypoparathyroidism for at least a duration of more than 2 years. And they should be on conventional mode of therapy, that is calcium activated vitamin D. The exclusion criteria were the patients who are on recombinant PTH therapy and patients who require thyroidectomy for malignant conditions which require suppressive dose of thyroxine, and pregnant and lactating mothers. And apparently healthy control, there was an age match plus or minus 3 years, and gender and weight matched apparently healthy controls, which are aged between 80 to 65. So these are the two group of patients, and they underwent clinical examination and then the investigations like calcium profile, magnesium, ALP, albumin, PTH, vitamin D, GFR, creat, and the bone turnover markers. For assessment of bone mineral density, we have done DEXA scan, then trabecular bone score, and to look for fractures, X-rays of dorsolumbar and thoracolumbar spines, that is lateral waist, and to look for hypercalciuria, we have done 24-hour urinary analysis and NCCT KUB only in patients of post-surgical hypopara, but in control patients, we have taken urine analysis only, spot urine analysis. Then we analyze the data. So these are the baseline characters. We included around 30 patients of post-surgical hypopara and 30 control patients. As we can see, most of the baseline characters are similar among them, whereas in cases, some patients have comorbidities like diabetes and hypertension, and indication for surgery is being benign thyroid swelling and PTC, which is low risk, which does not require suppressive dose of thyroxine in these patients. So these are the baseline biochemical investigations. We can see calcium, which is significantly low, that is 8.4 compared to 9.6, and phosphate is higher as expected, and ALP is similar. We can see GFR and creatinine levels are similar among these two groups. So these are the TSH values and PTH values. As patients are having hypoparathyroidism, PTH is suppressed. Vitamin D is normal, and we can see urinary calcium and creatinine ratio, a measure of hypercalciuria, is higher in patients with cases compared to controls, and the percentage of patients who had hypercalciuria is around 56%. And we had done the analysis for nephrolithiasis. There is no patients in our cohort developed nephrolithiasis or nephrocalcinosis. But however, on X-rays, there are 5 patients who had grade 1 morphometric fractures. And 5 of them are, 4 of them are asymptomatic, 1 patient was symptomatic. So this is the bone mineral density comparing the cases and controls. As we can see here, as I already stated, as PTH is low, there will be low bone turnover in these patients. And the lumbar spine BMD is increased compared to the controls. And other areas, it is comparable, like neck of femur, total hip, and distal third of radius, as well as TBS is similar among the two groups. So these are the sclerostin values and bone turnover markers. Sclerostin is inhibited by PTH. So in patients with hypoparathyroidism, the levels are more compared to the control groups. And CTS is a bone turnover markers as well as PNNP, which are both are low, indicating there is a low bone formation as well as low bone resorption in these patients compared to the healthy adults. So in this study, although there is significant difference in the lumbar spine BMD, it is not reflected neither in TBS or in total fractures. This study was observed to have low prevalence of symptomatic and asymptomatic fractures, that is 16%, which are the previous studies stating around 18 to 28% in the previous study. So one reason maybe the follow-up was lower in our cohort. So long-term follow-up may be required to look for further deterioration in the bone health. So even though the hypercalciuria is seen in these patients, none of the patients had nephrolithiasis or nephrocalcinosis. The limitation of this study being a small sample size and cross-sectional nature, and lack of monitoring for drug compliance. Thank you. So the conclusion is chronic post-surgical hypopara patients do not show any significant bone microarchitectural deterioration or no increased risk of symptomatic fracture despite being low bone turnover. So this study was funded with Endocrine Society of Tamil Nadu.
Manjunath, we now invite questions from the delegate audience. Both the groups and control group cases, they were on medication treatment,
Yes, ma'am. That is apparently healthy group, ma'am. Like, yes, ma'am. The patients who are diagnosed to have hypopara, they are on like calcium and vitamin D supplementation.
So you have compared the calcium and vitamin D levels and found that it's more in vitamin D is more in
Oh, that is like not very high, ma'am. They are in sufficient levels. The target for
there was a significant.
Yes, ma'am.
So that could be because of the treatment.
Yes, ma'am. These patients are receiving vitamin D as well as activated vitamin D and calcium to maintain the calcium in the lower normal range to alleviate the symptoms of hypocalcemia.
whereas control patients, we have not supplemented, we have just taken them.
What was the rationale behind the renal function in people undergoing parathyroid? Is it known to affect renal function in some way?
Yes, sir. Since PTH is having the reabsorption of calcium in the distal nephron, which acts on distal nephron and causes reabsorption. So in patients with hypopara, so there is no PTH level, and we are not treating with recombinant PTH also. So these patients are given just symptomatic treatment like calcium and activated vitamin D. Vitamin D acts on renal level, but sorry,
My question is about the renal function, mixed proteinuria, GFR. Calcium is okay, but you have studied the GFR and renal function, no? So
yes,
is there
these
a
patients are
non-association?
at high risk of developing nephrocalcinosis and like renal stones, sir.
Is it well described?
Yes, sir.
From hypoparathyroidism or the calcium you are giving?
Yes, sir. The calcium supplementation. Even if they don't receive calcium supplementation, also there is hypercalciuria, which is documented in these group of patients, sir, which predispose them to like nephrocalcinosis. And
Right. So you compare the GFR between the study group and the control. But why didn't you compare it with the baseline? That would have been more informative. So that because if you look at it, parathyroidectomy and immediately following that, there is no impact on the renal function.
yes,
And also, 36 out of 30 cases had either hypertension or diabetes, a significant proportion. And then you are telling the GFR is comparable with the people. So,
three patients. Three
3
patients.
plus 3, 6, right? 3 hypertension, 3 diabetes, so 6 out of 30. So that is significant proportion, and the GFR was comparable. You will expect some impact of the same, right? So they have comorbidities.
They were not very like recently diagnosed diabetes and hypertension.
My point is, it will be even more informative to change the GFR from before parathyroidectomy to
after conventional
comparing with the controls.
We'll try to look at that situation. The controls are from staff and patient attenders who are coming to our ward.
Thank you. We now invite Dr. Faisal from Pediatric Surgery to present a study titled Laparoscopic Appendectomy in Children with Complicated Appendicitis, a retrospective cohort study.
Yes. But there is that is not. What's not that?
Good afternoon, chairpersons, faculty, and audience. Myself, Dr. Fazal, resident pediatric surgery department. I will be presenting our study laparoscopic appendectomy in children with complicated appendicitis, a retrospective cohort study. Acute appendicitis is one of the most common pediatric surgical emergencies. The usual incident, a lifetime risk of having appendicitis is about 78%, with an annual incidence of 83 per 1 lakh populations. So acute appendicitis, the traditional management for acute appendicitis is appendectomy. Laparoscopic appendectomy is a choice of surgery for simple appendicitis. With the advent of minimal invasive surgery, this role of, due to good visualization, there is also role of laparoscopy in managing complicated appendicitis. What are complicated? The natural course of acute appendicitis is progression to complications. It can perforate, it can cause abscess, and then subsequently peritonitis. So complicated appendicitis, it includes perforated appendicitis, appendicular abscess, gangrenous appendicitis, appendicitis with peritonitis, and appendicular mass formation. The children, usually more of the children, they usually presented with complicated appendicitis. Approximately less than 5 years of children, if they present appendicitis, they usually have complicated appendicitis. And it is estimated that about 90% of the children less than 8 years, they have complicated appendicitis. The aim of our study was to compare the outcome of open and laparoscopy appendectomy in complicated pediatric appendicitis. It was a retrospective study which was conducted over a period of 4 years, included the data from 2020 to 2024. All consecutive patients presenting to our department with a diagnosis of complicated appendicitis were included in this study. A total of 74 patients were included, with 31 patients in open group and 143 patients in laparoscopy group, with a minimum follow-up of 5 months. We assessed the various variables, which included duration of the procedure, the need for conversion to open, need for drain placement, reception of orals post-operatively, duration of hospital stay, post-operative complications, and readmission rates were assessed in our study. If comparing the results, the mean age of our study groups, it was 7.48 years in open as compared to 9.55 in laparoscopy. Usually, slightly younger children underwent open laparoscopy, open procedure more. Male and female ratios were comparable. Mean operative time in open was 87.29 minutes as compared to 98.56 minutes, which was not statistically significant, but clinically it was more in laparoscopic, but not clinically that much difference was there. We had an early resumption of feeds in laparoscopic group. Feeds started on a mean day of 1.2 days as compared to open, who had started feeds after 2.23 days. In approximately about 58% of our patients who underwent open appendectomy, they had drain placement as compared to only 20% of the patients in laparoscopic group. As far as the length of hospital stay was concerned, laparoscopic group had a very shorter hospital stay of about 4.62 days, while as open had more hospital stays of 8.71 days. The most important complication after this complicated appendicitis is SSI, which was noted more in open group. 45% of the open group patients had SSI as compared to 4.2% patients in lab group. Initially, these also 6 patients, initially they were those patients who were operated initially. After that, we started the main SSIs in these patients was the umbilical port, the port from where we used to take the appendix. Then we started using bags or taking appendix in gloved in, which has drastically reduced the SSI rate in our laparoscopy appendectomy group. We had a conversion in 6% of the patients. Readmissions, we had 6 readmissions in open group as compared to 4 readmissions in laparoscopy group. The readmissions was for SAIO and post-operative abscess collection. All of the patients were managed conservatively except for 1 patient in open group who underwent radiological USG guided aspiration for that. Comparing our data with the literature available, our study was comparable with as far as the hospital operative time, length of stay, exercise, and post-op collection. It was comparable with the contemporary literature. We had a slightly higher operative time as in during the when laparoscopy was started due to the high learning curve. We had a higher operative time at that time, and now these days all the residents are only doing this laparoscopy appendectomy. So because of that, we had slightly higher operative time as compared to the other studies. Rest our parameter, all other outcome variables, they are comparable with the studies. So to conclude, laparoscopic appendectomy for complicated appendicitis is safe in children. It is associated with shorter hospital stay, lower wound infection, faster recovery. Operative time is slightly longer, but clinically acceptable. The laparoscopic appendectomy, even in complicated appendicitis, they have a better complication profile, less complications are there. The challenge we are facing is limited availability of laparoscopic equipment in emergency OT, which requires us to open our main OT, and the time from decision to incision is increased. So sometimes we are forced to, we usually do laparoscopic appendectomies here, but we are then forced to go for open approach as if the patient deteriorates, if the child deteriorates, or we are not having the slot available. This also takes a toll on our main OTs also. So how to translate into this practice, we can have a dedicated laparoscopic set in emergency OT, which will help us timely invasive intervention for children and improve the outcomes and recovery, and in turn decrease the cost. So take home message, laparoscopic appendectomy is a safe and effective even in complicated appendicitis. Laparoscopy should be the first choice in all patients of appendicitis, whether it's simple or complicated. With institutional support for emergency laparoscopic infrastructure, we can ensure that every child receives most optimal surgical approach without delay. Thank you.
Thank you, Dr. Pedro. We now invite questions from the judges and audience.
Other than the availability of laparoscopic in emergency, are there medical reasons why you may decide to go for open surgery for laparoscopic? And if that is, is there a confounding by indication there? Those complications may be more, patient may be sicker when you go forward.
Usually, if a child is having mods and all that at that time, but sir, the only when a patient presents to us, we have a score for pediatric appendicitis score. We assess the child with that. If usually the child with these complicated patients, they are very much dehydrated. So we first try to resuscitate the child. If we see that we can get a slot in our OT, we can get a slot. We will be able to open our main OT. Or usually these children present us during night, so we have a OT in the morning. So we try to resuscitate in between the child. If it is not getting resuscitated, child is deteriorating, we then are forced to go for open.
The sicker children who end up in open.
No, sir, there is nothing. That's it. Yeah. The time, if a child is sicker, means we don't have that much time from decision to incision. We have to shorten it. So within the child line, we are supposed to go.
Sicker children will end up with.
If we don't have that time gap for decision to.
Sicker children will expected to have more complications, right?
These children usually present with complicated appendicitis. They are high chance of complicated appendicitis.
In presenting your data, we always try to follow one pattern. Some place you put in percentage and bracket number and some other place number. And you said about the last of that it should be the first class in order to not commentate that with the laparoscopic study. Okay, so this is not a randomized control trial. This is the choice. And the third thing that you said that the result was based upon the experience of the there was some issue regarding the initial learning curve.
Time this operator.
You could have taken up only those cases which is after those that learning period. You would remove that particular file.
Initially, sir, initially it was operated. Now these days we residents are doing it.
For residents also, they can learn after maybe even after 5 cases or 6 cases. You take only those cases after that learning.
Point taken.
And remove that particular.
Question from the audience. Is there anything new that you got from this? It is well known that laparoscopy's outcomes are better. Is there, other than the fact that you're not getting OP, is there anything else?
No, traditionally in complicated appendicitis, it meant open surgery. But traditionally, if complicated appendicitis was, so it meant complicated. It meant open surgery, no lab. So they were wary of lab as they had during initial stages. There were many chances of intra-abdominal collections, conversion rates. So they were. It meant a complicated appendicitis meant open surgery. But we are not doing complicated appendicitis regularly with lab. So we just are highlighting this. It can be done.
Patients you do not operate.
No, we operate all. That in children, Austrian regime is not, that conservative approach is not followed. These are the extremes of age we operate.
Maybe that you can highlight that how many, you said there is a difference in complicated cases. Do you have any literature supporting that laparoscopic surgeries are not being done for complicated cases?
No, previously it used to be. In adults it is there. In adults it is there. Austrian regime is there. So complicated appendicitis, they used to conservatively manage it with antibiotic and then do internal appendectomy after 6 weeks in adults. But children it isn't. They are excluded from that regime, Austrian regime.
But the laparoscopies are not done as a standard of care.
So there are studies are there.
So you have to highlight what's the difference in.
Historical controls before you started using laparoscopic surgery complicated. It's easy to say you're taking controls from now. Those are a little selected properly. The JRC children, they are little bit from the operating thing. You have good data from your historical.
So these open cases, these are more these days. From last 6 months, we have done one open cases. These are usually of 2021, 2022, and 20. These are initial years. More open cases are there. And recently, we don't have open that much. We just, in the previous 6 months, we have operated.
Before you started doing labs.
Yes, sir.
How many years do you think?
Sir?
What? Since when is laparoscopic criticism available?
Here in JIPMER, it has been started from 2018, 17, 18, sir. It has been started from
If you take patients from before that, all of them will have gone through this. So it will be a more comparable.
Point out.
The thing, right? What is the sample that can be taken? That's the criteria and laparoscopy.
It was a retrospective study. It was just all consecutive samples. Whatever we have operated from 2021 to 24, we included in this and retrospectively analyzed in that.
Only 30 participants in the entire.
This 31 in open, we have done 30 versus 143 complicated.
In the case, I go with rather as well as there is the problem of indication. You are not sure. If you have a table for indication, you can put it that what is the indication to go for open or laparoscopy. Or if you are not able to attempt that, you can go for something called propensity score matching, where you can address this propensity scores where they are comparable at the baseline. That is a modified analysis technique that you can think about for.
Thank you to all the participants for showing their studies, and thank you to the audience for such an engaging discussion.
Thus, we come to the end of today's oral presentations. We will be continuing with these sessions tomorrow morning at 8:30 a.m. sharp. Thank you.
Thank
you. Thank you, ma'am.
And all the volunteers.